BBC, inspiring Uganda.
Good evening and welcome to Behind the Headlines. My name is Timothy Nyangweso. Today we focus on our journey on the fight of HIV and AIDS. As a country, what progress have we made? Even setting a target of 2030 to eradicate HIV and AIDS, is that possible? The 1st of December is a day we celebrate in this country and world over as AIDS Day. But what does that mean for us? As a country back in the 80s, the prevalence of HIV was higher. It was doubling every 6 months in the 80s. In the 90s, the government decided to embark on a combat to ensure that it goes away. That's when we had the acronym of ABC, when we had the bit where it was abstinence, be faithful, but also use condoms there. It brought it from about 18% to 6% to 5.5% to now 5.1%. But the biggest infections now annually are 54,000, and the biggest are young people, being ladies, adolescents, and young ladies. What does that mean for us as a country? At 5.1% prevalence in the country, and the biggest being Buganda, Ankole, meaning southwest there, at about between 7 and 6.3%. Is this fight possible? Is it feasible? Is it realistic? Or are we biting more than we can chew as a country? We take a deep dive into this conversation to find where our fight is, and looking at about 7 years from now, can we achieve it? I have a panel of doctors today and a professor, an expert panel, and I think by the time this evening ends, I'll be a doctor too. But they'll be speaking about what's happening here. So let me introduce the panel. I'll start on my extreme left, Dr. Vincent Bagambe, who is the Director of Planning, Strategic Information at the Uganda AIDS Commission. Good evening, sir.
Good evening, sir, and good evening to you, our dear viewers.
It's good to have you and to be here on Behind the Headlines.
Yeah, I'm very privileged to be here and to share in this debate.
Thank you very much. Next to him is no stranger in the fight of HIV there, Dr. Stephen Watiti, who is an HIV activist. Good evening, doctor.
Good evening, sir, and good evening, our viewers and listeners. I'm honored and privileged to be here.
Thank you very much. Next to him is also a doctor, Dr. Agre Semera, who is the head of the Department of Prevention Care, Treatment and at the Infectious Diseases Institute. Good evening, doctor.
Good evening, Mr. Nyangweso. Good evening, viewers. Happy to be with you today.
A dangerous substitute that just came in, and we're really grateful that he made it on time. Dr. Francis Kanyike, a public health specialist with the Joint Clinical Research Center. Good evening, sir.
Yes, good evening. I'm happy to be here, and I'm happy to represent my namesake, Dr. Francis Sali, who is the Deputy ED JCRC. But I'm also representing the entire JCRC community. I'm very privileged and honored to be here.
And I'm glad you're here because there's some researchers I was reading about that you are going to be on the spot to answer today. Finally, our very own Professor Sarah Sali, who is the Dean at the School of Women and Gender Affairs at Makerere University. Good evening, Professor.
Good evening, Timothy, and good evening, our viewers. Happy to be here.
Gentlemen and lady, Merry Christmas. I know it's too early, but Merry Christmas to all of you. Whatever joy Christmas brings to all of you, I hope it will be the same. For anyone watching us, go to our YouTube channel. We'll be there streaming live. But also you can be part of this discussion. Go to our X platform, drop your comment there. Let us know what you think about the discussion about HIV and AIDS in this country. You can also text us or WhatsApp us on the number 0709 62 25 92. That doubles both as our text line and our WhatsApp line. Let's get into this conversation. Gentlemen, a lady, and I think I'll start straight away with Dr. Vincent. Being that you were the center of the celebrations this year, you chose to leave conference halls for this year and come into the public. Give us the state of our fight on HIV and AIDS as a country.
Yes, thank you so much, Mr. Moderator, Mr. Nyangweso. And thank you for starting this discussion from there. So Uganda is part of the global community that is contributing to the fight against HIV and AIDS. And as a country, we have a plan, and we have a national HIV and AIDS strategic plan, which guides implementation of interventions towards ending AIDS by 2030. I should emphasize actually that His Excellency the President of the Republic of Uganda in 2017 launched a presidential fast track initiative, and it was part of the global drive, but he was the first in Africa to endorse this as a head of state, this fight against HIV and AIDS. And in this initiative, we have 5 pillars which we are implementing, and we think if well implemented, we'll see the end of AIDS. So the 5 pillars, the first pillar is engaging men to close the tap and prevent new HIV infections among adolescent girls and young women. So it's prevention. The second pillar is actually also prevention, and it is prevention of mother-to-child transmission. So we want to prevent infections in the adults, especially adolescent girls and young women. But we want also to end new infections transmitted from HIV, women living with HIV who are pregnant, transmitting it to their children. The third pillar is test and treat, that everyone who is HIV positive, we are able to reach out to them, test them, and start them on treatment. The fourth pillar is mobilizing resources from our development partners, from government of Uganda, from the general public, the private sector, and all, so that we are able to resource the national HIV response. And the last pillar is effective coordination, that if you are joining us in the fight against HIV and AIDS, you are doing it effectively, you are efficient, you are not just part of the bandwagon and not contributing much. So based on those pillars and our strategic plan, we've been making progress, and I'm happy that you've been quoting some of the statistics. We've been able to bring down the prevalence from the previous 18% in the 1980s and early 1990s to now 5.1%. We've been able to reduce new HIV infections. In 2010, the new HIV infections were in the rounds of about 93,000 to 100,000 Ugandans newly acquiring infections, HIV infections in 1 year. As of December 2022, we registered only 52,000. And the AIDS-related death is another parameter that we monitor. In 2010, we were seeing 53,000 Ugandans dying of AIDS-related deaths. As of December 2022, this figure had reduced to 17,000. In 1 year, 17,000 Ugandans dying of AIDS-related deaths. Of course, that figure is still high, but I'm showing that we have actually been able to make progress since this fight and the drive of ending AIDS by 2030 started. I should also add another parameter of coverage with HIV services. And as I speak now, 90% of the people living with HIV in Uganda have had access to an HIV test. They have tested and they know that they're HIV positive. Of those who have tested and know their status, 94% have been started on treatment. They are on their ARVs, they are taking them regularly, and because of that, they are living healthy lives. Now, of the people who are actually on treatment, on antiretroviral treatment, 94% have had a viral suppression, and of course, which means that then they can't get opportunistic infections, and that has contributed greatly to the reduction of new HIV infections, and it has contributed greatly to the reduction in the AIDS-related death.
Dr. Vincent, let me stay with you. Just a follow-up question, because you intrigued my curiosity. You said 5 pillars of this, 2017, but I also know you've had quite a number of strategic plans, 2015 to 2016, all the way to where we are. These pillars: engage men, prevent mother to child, end new, test and treat, mobilization of resources, effective coordination. Give yourself a red card of your performance here.
It's a mixed bag. It's a mixed bag because, so if we look at the general trend, we are doing very well. I know that by 2025, we've set a target of reaching 95, 95, 95. So if we are at 90, 94, 94, if it was a child in class, I think as a parent, you would be nodding your head. But the challenge is that when now you deep dive and start splitting the communities that we are targeting to reach, then the figures start looking quite different. And I will tell you, that's why we are saying, although we are targeting adolescent girls and young women to reach them with prevention interventions, we are still seeing many young girls getting infected. And similarly, when you look at treatment coverage, because we have tested, we want to put you on treatment, we want to achieve 95% coverage. We are at 94%, but when you look at the coverage among adolescents, you look at the coverage among children, 0 to 14 years, that coverage is not reaching 80%. So those are the gaps that we need to close. And unfortunately, unless we close those gaps, then our dream of achieving ending AIDS by 2030 will remain elusive. And that's why we have to split the figures, because if you leave them lumped up together, you will go thumping your chest thinking that you are progressing. But that progress is not happening. When it comes to resource mobilization, I want to use...
Dr. Vincent, I want us to come back to that.
Okay.
Because there are some numbers I want you to be able to explain. Let me come to Dr. Stephen. You've had these glossy, very beautiful numbers, how we have come from 18, but it's about 40 years, and now we're at 5.1%. But when you see some of the spikes that are in there in the central, North Uganda, when you look at Southwest there, as an activist, what picture do you see as Uganda AIDS Commission and government have done, especially in the fight against HIV and AIDS?
Well, we have come a long way. We have come a long way, like he has said. We used to lose hundreds. I mean, to get what died, and you know, all of us have lost this. And we have done tremendously well. We've got most of the people who are infected with the disease identified. We know them and they know it. We've got most of those who are identified, put on treatment. And most of those on treatment are doing fairly well, and I'm one of them. The problem, as you said, is when you zoom in, and when you compare ourselves. You see, when you are comparing ourselves among short people, we are doing fairly well. But we are not supposed to be comparing ourselves with short people. Look, nobody should be dying of this disease. If you go to Sweden, if you go even to England, people are not dying of this disease at all.
That's right.
They are not. And that's why we see, when you see, for example, that we are losing 17,000, I was checking, that means 45 people dying every day. 46, 45, 46, maybe 50. Mm-hmm. And again, when you zoom in again, you find that they are men. Mm-hmm. Men are supposed to be leaders. Why should men be dying? Mm-hmm. And with this disease? It is annoying, very, very annoying. And what annoys me most is that when you go for these funerals, people say, God has called these people. So I'm not God's spokesman, but really, why is he calling those people in Europe and in America? No, none of them is dying. So, and I'm not blaming the Uganda AIDS Commission. I'm saying we need to do all hands must be on deck. Make sure that nobody dies of this disease. Look at the infections which he talked about, and one of the one which you know is most is the one of children. If you check the statistics, we have about 5,000 babies, I'm told,
Yeah.
being infected with this disease. That would never happen in Europe. In fact, if it happened, I think the whole government would fall.
It's an audit.
So, and yet this is the easiest, the lowest lying fruit. We see a woman pregnant for 9 months, and none of us does anything. They come to church, they go to the market, they change their dressing. You know this one is going to have a baby. And we know that any person who is going to have a baby has a man behind her. And these people have had unprotected sex. This is the main way of transmission. Why don't we intervene? Why should this happen on our watch? Especially babies. So, yes, we have done very well, but we are going we're very far, and I think we have a long way. I really look forward to, not in 2030, but we could stop, especially, we could have 0 new infection among babies. I want to see districts where we say, in my district, in Mbale district, for example, no baby was born with HIV. Unfortunately, I don't think there is any district which can report that.
And Doctor, let me stick with you. You have been an activist in this area for a while. When you compare the fight in the 90s and now, many suggest stagnation in the fight. There was ABC, it was at the forefront. It drummed so many. There was a champion then, the late Phile Bongole Lutaya. When you compare the two, the fight now and the fight then, what is the missing link?
Maybe it's not fair. It's like comparing goats and cows. So I wouldn't want to compare. They're all animals, but they are different. The face of HIV has changed, and I was there. Because I remember I heard about this disease when I was an adult in the medical school in 1983 there. It was there. And I first saw a person with AIDS when I was an intern. And I remember that gentleman very vividly. Now, looking at that coming down, of course, the figures, was it ABC which brought it down? Oh, these people died anyway. I don't want to vent that. These people were dying. And they were so sick that many of them were not transmitting HIV anyway. Now, when you look at people who are transmitting HIV now, many of them don't even know they have HIV. In fact, now, it is people, for example, most women who are getting, I don't have the statistics, but many women, when they go to check, they are negative when they go for antenatal. But along the way, they get infected. And these children get what? They get infected, they get children. Because I was at Mildmay, I worked there for almost 10 years. And by the time I left, none of our patients who were having babies were having what? And I'm sure Dr. Semele would say the same. At even JCRC, you check people who are on treatment, none of them transmitting HIV. Who is producing these 5,000? It is people who even don't know they have HIV.
That's right.
So, as I said, I think comparing then and now we're comparing two different animals. The face of HIV has changed so much, and yet it is still there, still infecting. But we could pull ourselves together, as maybe we could talk about that later. What can we do? Guidance Commission, myself, you, and the other one. What do we do to make sure that even before 2030 we could go to Kololo and announce that this war, some front we have overcome, so we can now rally here. But we need to, I think we need to have this kind of work where we can say, okay, here is a front, let's punch a hole in here, and let's punch a hole, for example, in mother-to-child transmission. We can just punch a hole in stopping new deaths of men. Why should men die?
Thank you, Dr. Vincent. Dr. Gray, and I'm glad Dr. Vincent referred to you because my next question was coming.
Vincent is this
Sorry,
one.
Agre is right here. So when he mentioned the comparison, young people today, most of the ones that 35 and under, we could say the evening of the 1980s, the earlys of the 90s, really these discussions of ABC, Phile Bongole Lutaya's songs might not resonate with them. We have a big picture that looks good. 5.1%, 54,000 new infections annually, about 1,100 weekly. What are we missing with this fight?
Yeah, it's a good question. You know, the understanding of populations will always tell you that a generation is about 22 to 25 years. As we speak, we're about 20 or so years into this epidemic fight. we have come a full generation. And so what we did a generation ago might be completely unapplicable today, yet the enemy still is the same. In Luganda we say, enswabo ekyusa amaaso nga nawe okyusa envubo. Basically we need to also tailor a message that fits our generation. We need to speak about, yes, we talked about ABC, but maybe we might need to also think about, I've always said this, how can we use Twitter? How can we use TikTok? How can we use what young people understand? Right now the drivers, our population is majority young people, 75% young people. They are looking for opportunity, and they don't care how far they can go to get opportunity to achieve their aspirations in life. Sometimes they're willing to take risks, some of which most of us can count as risks. For them, they are not a risk, because you're going to tell them there's post-exposure prophylaxis. There is, you know, and so someone can say, for the sake of the money, I'll take that risk. And so we have to rethink quite deliberately what we are doing. And I think my colleagues from Uganda AIDS Commission, of course, can lead us in this, and even us as researchers can, and the care providers can provide some insights into what we are learning from our friends and the people out there who we go and test. Let me give you something I heard that was so perplexing, and I sort of confirmed it just in the last maybe day or so. One of my team members was telling me there's a lot of STIs among street people, street children. And I was like, how so? These are people on the street. How do we provide prevention to them? They're all young people, right? And I saw, I think, also a message from Bali, actually, in the Monitor today about, you know, young people, street children paying off sex workers, and they are getting exposed to HIV, some of them testing positive. How do we reach some of these groups that are microcosms? The picture looks good from above, but there are small areas, there are pockets, and these pockets need tailored approaches. When you are dealing with a battle, it's very easy to clear the big, you know, obstacles. But now is the time to focus in on those small key areas with very targeted approaches so that we can clear and stabilize the fight.
And when you look at this fight,
Yeah.
I'll go back to it. When you look at the numbers, especially for the young ladies, the adolescents, the ones between 15 and 25, especially coming from the report that Uganda AIDS Commission presented on the 1st of December, you wonder, why are the ladies having these infections so high? And when you look at the men, it looks so slim, yet it is the men that give them these infections. What's happening there? How are these dynamics really what I could call a square hole in a round peg?
Or a round peg in a square hole.
It's just upside down.
Yeah. It would take us a whole evening of discussions, and Dr. Sarah, Prof. Sarah can tell you that understanding that dynamic, let me just paint maybe the picture a little bit more. When we talk about, for instance, suppression of virus, the young people between the ages of 15 and 24 have the worst indices. They're just 50 to 60% suppressed. They have the highest infection rates, infection percentages. But we also know that we have the highest teenage pregnancy numbers in the region. COVID just did show us that. And then, of course, to bring this home, there are, of course, social issues around girls. And I saw the president recently saying we need to keep the girl in school. something I agree with 100%, and somehow COVID sort of, flipped it on the other side. We need to deal with some of our cultures that, disenfranchise the girl. The boy will stay in school, but the girl will not. We keep saying this, but, it's a reality. You walk into the villages and you'll be surprised. That young lady selling you tomatoes on the roadside, you ask her age, you'll be surprised, and she has a baby. And so it starts off there. But then who's marrying them? It's the older gentleman who has tried to get something going. Maybe he has some income, and so he can actually marry someone. The little boys cannot, because somehow they have to earn. And so that kind of thing is staying with us a little longer than I think it should. And remembering that we have a large proportion of our population in that age group means that actually we have to focus in there.
Thank you very much. Let me come to Dr. Francis. Doctor, you have been at the forefront of this as a Joint Clinical Research Center. When you look at this fight, and let's get to the young people now. Let's look at just the young people. The ones, because they have the bulk of this population. When I look at some of the statistics that were shared then, this fight that we're looking at, how are we doing? Are we losing the war and winning the battle? Where are we?
Yes, well, my colleagues have mentioned a few statistics, but I also have some good news. Yes, I like talking about good news before talking about the problem. Yes, the good news I have here is there is reduction of HIV infection among the newborns by 77%, from 20,000 cases in 2010 to now 5,900 cases. That's good news, right? But and that's because, like he mentioned, like we've had strategies, PMTCT, that we've been preventing the infection. But then the other issue that I wanted to mention there is now most of the HIV that we see in the newborns is actually not coming from women who are on chronic care. I think that is important to note as we think about the strategies that we need to focus on as we address.
So where is it coming from?
That's the reason we're discussing today, and I'll tell you. But allow me mention another piece of good news.
It's Christmas.
Yes. So the new HIV infection in Uganda have reduced from 88,000 to, that is 88,000 in 2010 to 52,000 in 2022. That's another piece of good news. And majority of these new infections, like they've mentioned, are among the young population. And the reason is the current cohort of young people were not part of the previous public health interventions. Like they've mentioned the ABC, like where the battle or the struggle started. Like,
so, Dr. Francis,
yes.
let's put these statistics in perspective.
Yes.
88,000 in 2010.
Yes.
52,000 in 2022.
Yes.
Meaning the reduction is 35,000.
About 35.
In 10 years.
Yes.
That means you've been reducing 3,500.
Yes.
And we still want to get to 2023, 2030.
Yes.
With no HIV and AIDS.
Yes.
It's still realistic and feasible.
If we
go by these numbers, 3,500, for the next 7 years, we will not get there.
No, the thing is, if we can address where the problem is, we can actually get there.
Where is the problem?
Yes, where is the problem? And I'll tell you where the problem is. Now, where are the sources of the new infections that we have? So we have individuals that have not tested for HIV, okay? If we can embark on testing, because the truth is, if you test and you know your status, then you can get into care, and once on ART adequately, we can prevent and we can probably reach our target. We have individuals that have disengaged from care. Those they've been previously positive, and then they've disengaged from care. So if we can trace these and bring them back to care with the treatment regimens that we have, depending on which status they are. If they are having issues with resistance, if they're having issues with viral loads, we can address these issues and get to our target. We have individuals that are actually sexually active but have not achieved viral load suppression, probably due to ineffective ART, probably due to HIV drug resistance, probably due to poor adherence. If we can trace these and we address their issues, then we can have some light towards achieving our target. Okay? But most importantly, like I mentioned earlier in the beginning, testing. Testing, very, very key. Because once you know the status of someone, then you can give them treatment, and once on adequate treatment, we can have some light towards achieving our target.
And I'll come back to you, but let me come to Professor. Professor, some of the things Dr. Francis is talking about are scientific. Move out of here. We're going to leave here at midnight. Go down, speak. There are young girls there.
Yeah.
The economy is hard. We have 40,000 young people that leave universities. We have government trying to come up with 700,000 jobs. Only 300,000 available. 400,000 is the deficit. There is medication, which he hasn't spoken about, which I'll come to him about. A report shows that by 2025, we will have 2 million people living with HIV, not ready to access medication because it's not available. Funding, I will come to Dr. Vincent. Gender-based violence. Why are we not dealing with these issues?
Thank you very much, Timothy. Once more, good evening, viewers. I think the previous speakers have spoken well, but I think they have mainly focused on behavioral issues. And I think behavioral change was one of the key pillars of why the epidemic was handled, like the way it was handled in the initial years. Because they focused on those same things, you know, treat, enter into care early. Of course, by that time there was no treatment, but there was testing, there was entry into care early. If not, at least you lived positively. We had something like positive living. So it was largely around behavior interventions. But even when it was behavioral, it was not a preserve of the medical people. Everybody came on board. You remember, maybe you were young, but at least we remembered everyone who had a public platform was charged with saying something about HIV. So whether you were an imam, whether you were a pastor, whether you were doing everything, everyone knew that there was HIV. And maybe as also fate would have it, is that the HIV of that time killed, and you saw it killing. So you saw the person suffering from HIV clearly, and the person wasted, and the person died. So that created some kind of fear, okay? So the efforts then were around prevention through behavior change. And that generation, it worked like that at the time. But I think they themselves will tell you that in the last 10 plus years, they have been focusing more on structural drivers. Because the behavior is individual. What can you do differently to change what you're doing or the course of things? But when individual actions cannot deliver what you want to deliver, it's important, or when people persistently behave in a particular way, it is important to ask, what are the underlying drivers of the epidemic? And medics have published about these things, in as much as social scientists have published. For example, when I was preparing to come here, I read an article by Francis Bajonire, by Dr. Sese Chitio, by Dr. Mujenyi. There were quite a number of them. And they mapped the drivers, the structural drivers of the epidemic. And these included gender issues, okay? Women's inability to negotiate safe sex. They documented social-cultural issues. They documented economic drivers, the things you're talking about. People are leaving university, people need to survive, and there are just no opportunities. And the available opportunities are risky, like Dr. Semere said. And then people take the risks, hoping that things will turn out differently, especially when you did not see what the initial AIDS was, okay? You hear about HIV, you're not actually seeing AIDS, okay? So people are taking these risks. But also, I think, okay, the other thing they mentioned were things like the availability of phones, the availability of a different kind of lifestyle. So there's a lot of modernization and lifestyle changes, and people are making choices based on so many other things, and sometimes the younger people are engaging in risky behavior. I mean, at the time we grew up, or at the time of the initial pandemic or epidemic, testing was very important for anything. To get married, you tested. To do this, you tested. To travel, you tested. But these days, I mean, people are not scared of dating whoever they date and go. But again, you don't blame them because they have not seen AIDS. They only hear about HIV, and maybe that's why that is resurging. So I think in addition to those structural drivers that the Dr. Chitios and the rest document, there are also the other drivers that have come in, that as we are modernizing, there's a lot of migration and mobility. There was another study which was done by Dr. Kamian team at the IDRC Center, and they did this around, we did this around the East African region, and it was mainly tracking migration and mobility. And there are those populations which are very migrant. So that still continues. It affects their stay in care, but also encourages them to engage in different kind of that. So I think now, even in the gender field, people have moved away from simply behavioral interventions of say no to this and say no to that, to focus on what are the norms that drive things like gender-based violence. Gender-based violence survives because there is a cultural norm that a woman has to be disciplined physically. But also that woman who is being disciplined physically has also internalized the norm that a man who loves you will beat you, okay? So you have these things going on. You have a cultural norm where people think hitting on you sexually is a good thing, when actually it's a dangerous thing, okay? That's why we have some of these vices in schools, you have some of these vices in workplaces. Even when men are married, you find sometimes younger people are ready to go there, or the young men are also coming down to the younger people, thinking that the younger females are safer, and maybe that's why you're seeing, the medics are seeing the things they're seeing. So we have a lot of negative cultural norms that have to be dealt with. In the first epidemic, these to an extent were dealt with because everybody came on board, including the traditional leaders, to say this is not right. So the custodians of the cultural norms were brought on board to fight the epidemic. Right now, what we hear, like my neighbor's statistics, the viral load and all those things, and they are very good things, very good science. We need it because it has been very, very important sustaining this country. But we need to go beyond that, maybe to look more at what the Dr. Semeres are doing in the community and what Dr. Watiti is doing to find out what are these structural drivers. If we are to target, like Dr. Watiti says, that there should be no child born with HIV in my community, what actually do you need to ensure that happens? It means the facility has to be there. The treatment for PMTCT has to be there. The transportation of this mother has to be there. But also the husband of the mother must also not engage in risky behavior. So it is a holistic package of things, so that which when addressed, these kinds of things will be dealt with. Also things like stigma. But of course I was also disappointed, and maybe this is the one time we need to thank the parliament for saying no to the policy of giving contraception to girls. Of course, we are dealing with a big teenage pregnancy scourge on the continent and as a country within the region. And it is important that we control that. But is birth control the solution when we are talking about HIV increasing? Because we know that what can control birth will not necessarily control HIV. So if we are going to have a free reign, because now you have birth control, and as the Deputy Speaker, the Right Honourable Deputy Speaker said, it was going to increase defilement, because now the men would go for the younger people, because after all, you're on birth control. The government has given you birth control, so there's no longer fear, okay? So the danger that then would create is, while we would be protecting pregnancy, preventing pregnancy, we might actually end up increasing HIV. So what I want to say is that HIV is very much a social disease in as much as it's a medical disease. Yes. Its drivers are social, its interventions and management is medical. So while the medics are doing their things, we also need to ensure that the other side is working. So this calls for more partnership between the medics and the people who are in the communities. Of course, we accept that, we appreciate that between the first epidemic and the current, there's been so many things. The economy has changed, neoliberalism has taken effect, retrenchment has occurred, so jobs are not stable, but also you have COVID has come and taken the space, so the Ebola came and also took the space. And each time we are told that we are using the template of HIV to manage these pandemics. So can we have this template back to managing HIV, so that we, even as we are worried of teenage pregnancy, we should also be worried of those who are impregnating the girls. Because in addition to pregnancy, they will give them other things. So I think now is the time to go back to these negative cultural norms, which are the social drivers of the pandemic, so that we don't increase the costs in terms of labor and finances and medicine on the medical side of things. Thank you.
And you bring a very interesting perspective, especially on behavior versus the structure there.
Yeah.
And how do we find the balance of that? Because today you find a young girl, an adolescent or a young girl telling you, you know, I don't fear HIV, I fear giving birth or getting pregnant.
Wow, is that true?
Stereotype, they're here, they're doctors.
That's true.
It's true.
It's actually very true. They will tell you that.
Yeah, but also you need to ask this younger girl who is getting her pregnant. Okay? Mm-hmm. And normally they are not actually being impregnated by their age mates. They're being impregnated by older men who are looking for extramarital affairs away from their homes, but thinking these girls are safe, they are young, they are naive, they are. So if we go to what everyone has said, that we bring everybody on board, and someone talked about a man is supposed to be a leader. I think it was Dr. Watiti. So if a man is supposed to be a leader, these are some of the things you need to look at. I think we need to go back to what it was at the past. You know that HIV is here. All of us are at risk of catching it. You know, in the past, there used to be even a more scary thing. The taxis then had this thing whereby, like for the speed, because we also had a lot of road traffic accidents. So if a taxi overspeeded to a certain level, the issue of the coffin highlighted on the dashboard. So it was a little bit that scary. But we also used to have a lot of these campaigns on radio and on TV about HIV. You could hardly spend 3 hours without hearing an alert about HIV. And maybe if the younger people are on social media, probably we follow them on TikTok, Instagram, Twitter, Facebook. Maybe that's where we need to take them. So we need to do something. One is continue focusing on the behavior. But to enable the behavior, tackle the structural drivers. If certain cultural habits are not necessarily helpful, the government needs to do something. I know we're in an age of cultural revival where every people have their right to perform their culture. But if there are cultural habits which are not good and are driving the epidemic, we may need to say something about it.
And Professor, even as I come to Dr. Vincent, you talk about behavior, and they have spoken a lot about structure. How do we influence behavior? Because it's one of those drivers that is an undertone, yet it is influencing a lot. Look at culture versus westernization.
You see, there are two things, Timothy. Behavior is what you can do as an individual. But for you to do, the way you act is determined by a structural base. That structural base could be your culture, it could be the schools you went to, it could be the peer group you are in, it could be the economy, it could be your religion, your socioeconomic class, it could be your religion. So these two things are not separate. The structure, it's like the foundation. It provides the base for the way you behave. So if culturally masculinity is displayed this way, someone will behave that way. So for people who are able to say no because they have the means, they will say no. So they will be able to engage behavior change and say, I will not accept to be sexually harassed because I am that powerful, okay? But now, for a person who cannot say no to sexual harassment, there you don't blame that person for falling victim to that. But you go for the structural base which is making harassment possible or inevitable for such people. You go for the structural base which is making teenage pregnancy the default thing that happens if you have a lockdown, okay? So a person like me may say no to pregnancy because I have the means and I have the age and maybe some little clout, but a 13-year-old girl who is staying with a predatory uncle or a predatory neighbor or a predatory teacher, as young as she is 13, 10, she can easily be locked up in a house. So although she does not want to do what this person is telling her to do, she just doesn't have the means. She's physically weaker, okay? She sometimes doesn't know whether what they mean to say is what they mean to say. Or like you talked about gender-based violence, many women stick in there because they don't have alternatives. And leaving means you're leaving your children to a stepmother and you don't know what will happen. So there are all these things, and if they had time to go into what they document on the community side of things, all of these things have been documented.
That's right.
So that's why they push for both. So they push for the behavior in terms of come and test, come and be counseled, let us know where you lie, engage in treatment, but if you're still negative, say no to the following. And some of the people have acted like that. If it is a risky relationship they are in, they have said no and moved on. But then there's also need to attack the structural base. That makes certain behaviors inevitable.
Interesting there. Let me come to you, Doctor. And very many things said here, and also a report that you presented. What new factors did you find, especially in the change of the dynamics between 2010 and 2022, that really, to you, were an eye-opener and we need to find medicine for them?
Okay, and maybe I will start off from the question that I think you had posed to Francis. If we were at 83,000 new infections in 2010, and we are at 52,000 new infections per year by 2022, how shall we get 0 new infections by 2030? One, and I think it has been said here severally, that the HIV phase of 2010, of 1990, 2000 is different from the phase of today. And one change is actually HIV, the coverage with antiretrovirals. In 2010, I think about 50%, if not less, of the Ugandans living with HIV had access to antiretrovirals. As we talk now, of course, we are saying 90% of the people living with HIV are accessing antiretrovirals. And indeed, those who are not accessing antiretrovirals, it's because they don't know that they are living with HIV, they are HIV positive. Every time we test people and we find them to be positive, we put them on treatment. And then there is also the other challenge that even as health workers, we have a task of identifying then those who are positive, they don't know they are positive, and yet they are out there transmitting infection. And for us, that's the gap that is giving us nightmares. I will tell you that...
Sorry, Dr. Vincent, let me ask. You talk about medication, 90%, it's a very good number. But we've also heard of people that are failing to get medication. One, because they have run out. Two, the medical facilities are too far from where they are.
But the medication is feeding pigs and
so that's also, thank you very much. And that's also something that is also there. ARVs are being used to fatten pigs and chicken. The 90% seems a good figure on the national level. What does it look like in a district? Kotido, Busia. What does it look like in these places that have the high prevalence in southwestern Uganda, in northern Buganda? What does it look like? What are the real issues of medication?
So actually we have broken down that figure up to the district level. So we know the coverage, antiretroviral coverage in each and every district in Uganda. We have actually also split it to the cities. We may not have gone actually to the municipalities and the smaller towns, but we know the antiretroviral coverage per city, per district, per region, and of course then the national one. And that helps us to identify the factors. Surprisingly, if you go, for example, to southwestern Uganda and the western up to Fort Portal, the antiretroviral coverage is high. If you go to districts in the North Central, I think Lira, the Lira region, they are doing well. But if you look at the Acholi region, then the coverage is not as good. It's not reaching the 90% average that we have talked about. The 94%, sorry, average, national average that we are talking about. But it boils down back to the social behavioral factors. I will tell you that every facility up to Health Center 3 in this country is able to provide antiretroviral treatment. We have a laboratory system that works in such a way that if you are in Moroto, and another one is in Chihihi in southwestern Uganda, and another one is in Moyo or wherever, if they need to monitor their viral load, this sample, either it will be tested in that facility or it will be transported to where there is capacity to test that sample, and we get the results within 1 week, maximum. Others it's 24 hours, others it's 48 hours. So if we have the drug, and you are talking about drug stockouts, you know, the challenge we have is that bad news spread faster than the good news. So if there is one stockout in one facility, out of the 3,000 facilities where these services are offered, it will be louder. But I will tell you, even this morning we were reviewing a report where data was collected from service users, people who go to the facilities to consume these services. And they were asked to rate accessibility to these services. And one of the positive things that they were documenting is that every time they go to the facilities, they find the drugs there. So for me, stockouts actually is not the problem. You talked about the issue of people feeding antiretrovirals with to pigs, and perhaps to chicken, and I don't know which other domestic animal is fed onto this. And I don't want to refute it, but it boils back to individual behaviors, because government will put the drugs, will procure the drugs together with partners. These drugs will be transported to the health facilities. We will educate the users. You must take your drugs consistently. But if one individual chooses not to take their drug, and that is, it takes us back to the problem that we think you are taking your drugs consistently, but for you, you are taking part-time because you want to reserve some, maybe to sell to your neighbor to feed to the pigs.
Give your pig.
Or to give to your pig if you own the pig. So all that keeps rotating back to behavior, the social, cultural factors. And I can assure you that we have all these programs in place. We have the health workers, we have the equipment, laboratory equipment, we are monitoring those who come, but the challenge is those who are not coming, or those who are there and they have taken our drugs, but they are not using them according to how we have educated them to use them. Because maybe they want to reserve some for pigs, but and we have had also men who fear to go to health facilities to collect their drugs, and then they wait for their wives to bring, and they want to share. So we've given you your doses for a month, and we've told you come back after a month or after 2 months. But when you've reached home, then you are now sharing with your husband, which means instead of 30 days, it will take you 15 days, and you'll not come back because we told you come after 30 days. So the social issues is what is dragging us back. And we must work on this together. It's not a battle for health workers alone. It's not a battle for the counselors alone. We can take as many times of drugs as possible. They will be misused as long as we don't have the entire social fabric. The religious leaders playing their role, the cultural institutions bringing in to dispel the cultural myths and misconceptions and misinformation, the media using all your platforms, including the platforms for the young people that Dr. Semenyo talked about, and so on and so forth. This is a battle that we must continue fighting together like we used to do in the past. We have become victims of our success. That in the past, in the 80s and 90s, every person who lived with HIV, you would see, either they would have the symptoms. We would be traveling to the village almost every weekend and weekdays to go and bury. With the advent of ARVs and the high coverage, that picture is no more. And indeed, as they said, the new generation doesn't have that picture. I've interacted with the members of parliament, and they keep saying, but Uganda AIDS Commission, you are not loud. Those days we used to hear drums every after the news. The drum is not there anymore. I can tell you that if you beat that drum on this UTV today, and my daughter hears it, it will not make sense to her.
Yeah.
It will not, because for us they would beat the drum, and your classmate the following day, the symptoms are there. We have given ARVs and they have erased all this. Therefore, this face of HIV that has changed, you must look for new ways of delivering the message to the people that we want to protect. We must take back the challenge to everybody that if you are a politician, and politicians usually get platforms, whether it's Lumbe or a wedding or a Kwanjula, they will call you and say, greet your people. So if you have greeted your people and you have not used the opportunity to give a message about HIV prevention or seeking for services, you are doing a disservice to your people. The teachers, they are the ones actually with these children. But I shouldn't forget us, the parents, because as we are all here, we have children in our homes. Have we ever taken a minute to talk to our children about HIV and AIDS, how it is still a reality? Because many of our children, they are failing to appreciate that HIV is there. And I agree with somebody who said that young girls now fear pregnancy more than HIV, because they will become pregnant, tomorrow daddy will see that the morphology, the figure is changing, and will ask questions. Whereas for HIV, if they are ARVs, of course, in the home, if you are an observant parent, you will see whether if somebody is on treatment or not. But shouldn't reach there. We have the platform. We are always with these children. We go to visit them at schools. If these children are out of school, we are interfacing with them on almost weekly basis. We must take it upon ourselves as parents, and as we are telling our young people about the challenges of life and the lessons that we've gone through, HIV must always be one of the key messages that you pass.
Okay, we're going to take a quick break, but when we come back, we'll be internalizing some solutions there, but also how do we put the social fabric of this country back together? Even as Professor suggested, we start with the structure. Where is that structure? Things like the economy.
Culture.
How do we deal with them moving forward? How do we get cultural leaders, religious leaders on board? But also, I would like to interrogate the first pillar, engagement of men. What does this mean? And also what Dr. Stephen said, you know, men must be leaders. What is that criteria? This and more after this break.
Meet Brian Namanya, a visionary and a game changer whose team at Tubayo is breathing new life into domestic tourism by curating exciting yet affordable experiences for Ugandans and foreigners to enjoy. With the help of technology, Brian is showing us all the immense potential out there. Those who know Brian know him as a serial entrepreneur who's always been challenging the status quo and won't stop now. Brian, we're in your corner. You are unstoppable. MTN, the Unstoppable Network, celebrates you. Visit www.tubayo.com And together, let's support Ugandans like Brian, who are driving our country's unstoppable progress.
Metu Bus Industries, Namamve, the manufacturers of buses for transporters, schools, tour operators, and special purpose vans and any customized vehicle. Metu Bus Industries offers a range of buses known for safety, comfort, and reliability. Depending on your needs, a bus can simply be a point A to point B people mover with just seats, or a special design that includes power outlet, Wi-Fi, television, refreshment center, and any other specification. Buy your buses from Metu and support industrialization of Uganda. Contact us on 0788 118586 or 0782 030303. Email us metuafricabus@gmail.com. Visit our website www.metubusafrica.com.
Junko. Yo. Check the shopping, man. What's your secret?
Haven't you heard of the parish development model PDM?
Yes, I did, but I thought it was just a talk.
No, Sebatia. It is real. I and a few friends together formed a circle, accessed money from the PDM, invested in a poultry project, and now things are moving.
Junko. I thought I was one of your friends.
You are.
But you left me behind.
I didn't leave you in poverty. What you do, just visit your LC2 chairperson and your parish chief and start the process of economic transformation. Just like that. The parish development model is an initiative from the government of Uganda through the Ministry of Local Government designed to transform all lives of Ugandans for the better. PDM, my parish, my development, my life.
Welcome back from that quick commercial break here on Behind the Headlines. Even as we get to this last leg of our show tonight, my name is Timothy Nyangweso. We're discussing and reflecting on our journey as a country on the fight of HIV and AIDS, where we have set a target, come 2030, would have eliminated it. Is it possible? Is it feasible? I have the professor in the house, and I also have doctors in the house to put perspective to this. We have a lot of feedback coming through. I'll be getting to that in a short while, to be able to respond to some of the things you'll be saying there. The doctors here will be responding to it. But we have discovered there's a social issue and a structural issue, and we need to be able to handle some of those things going forward. Dr. Vincent, let me come back to you before I get to Dr. Stephen. The question of funding. Uganda AIDS Commission and all its affiliates that are doing this fight together. 68% of this money is donor funded. 12% is government. 20% private funders. How do you hope to have sustainability of fighting this by 2030 if funding is still a big question?
And indeed, yes, the funding is a big question. Let me say this, that the financing the HIV response is expensive. Right now, as a country, we use over 2 trillion per year to provide HIV services across the country. Actually, out of that 2 trillion, almost 1 trillion is spent on procuring and distributing antiretroviral drugs. So, looking at the budget of the government of Uganda, which is about 50 trillion, if 2 trillion of that is looking at one disease, and yet we have so many other diseases that the government has to take care of. It's really a challenge. And I want to thank our development partners who have come in to shoulder that substantial amount that you have mentioned. I want also to be positive about the government of Uganda. Again, there is a report financing the National Aid Spending Assessment, which will be coming out soon. And when you look at the trends of financing from government of Uganda, it has been increasing. And the government has now committed through Ministry of Finance that each year there will be an incremental addition of 50 billion to what the government is already putting in. So you are we actually, government is contributing 13%, but this will continue to increase. So by your question of by 2030, will Uganda be able to sustain the response if there is no donor support? Clearly, of course, the answer is no. But we shall continue working with our development partners. I think for me the more important thing is that the government must continue to shoulder the bigger responsibility with the aim that ultimately, of course, the critical issues, the critical areas of the response are supported by government. And to this, it is taking steps. I've already told you it is spending over close to 300 billion directly into the response now, and it has said every year it will be adding 50 billion. In addition to that, government issued a directive to all ministries, departments, and agencies, all government agencies, to be allocating 0.1% of their budgets and assigning them to priority HIV interventions that are unique to their departments or to their ministries or to their districts. And this is happening, and through this approach, an additional 40 to 50 billion is allocated towards HIV, spent within the agency, and don't ask me whether it is being spent effectively. I think for me, the fact that they are able to say this money has been put aside to support HIV interventions is homegrown. It is something, if we continue fine-tuning, will be sustainable, because these government departments are here to stay. They will continue allocating, and we know that this is a sustainable way of contributing to the to financing the HIV response. Of course, we need to look at the other things. When we say that will the response be sustainable, we shouldn't only be looking at government financing. Should be looking at what are the other things that we can do domestically that will make it, will not require, for example, dollars to go and get from outside. And of course, we know government has supported the private sector. ARVs are being produced here. But what else can we produce from here? So that if we are buying it, we are using Uganda shillings and we don't have to use dollars. For me, I think as we look at sustainability of this response, one, we can't say that we will do away with donors immediately. We will continue managing the relationship with the donors. We must see government of Uganda taking responsibility and adding more resources, but also being in charge of setting the priorities. And we must also continue to grow this initiative of getting every department. So if government departments have started mainstreaming, what if we also got the non-government entities also allocating that 0.1%? What about the private sector, these corporates, the MTNs of this world, also allocating, and then identifying one area, unique area, and we say, let's focus, for example, on prevention of transmission of HIV to these young people. I think for me, we can have a sustainable way of mobilizing these resources, and we will have an impact on one window through which these new infections are passing, and would be clearly on the right path towards ending AIDS. I should if you allow me, I want also to clarify when we say we want to end AIDS. what it means. Because most people hear us talking about ending AIDS, and they think that by 2030 we will not be having any individual in Uganda living with HIV. That's not what we mean. What we mean is that by 2030, we want to have 0 new HIV infections, 0 AIDS-related death, 0 stigma and discrimination. If we can achieve that, then we know that the people who are living with HIV, we will be able to manage them, provide them with antiretroviral drugs, with the psychosocial support, and maybe, and we, by the government also, we shouldn't forget, beyond the health sector, government has had interventions. They have interventions that are fighting economic vulnerability. You've just run an advert here talking about the parish development model. If well done and the real vulnerable people are lifted out of poverty, that alone will have impact on reducing new HIV infections that are resulting because people are desperate. A young girl cannot buy pads, so for them to be provided, somebody takes advantage of her. This woman who is selling her fish, because she can't keep them in her place, they wrote maybe she needs a fridge. That causes a vulnerability, and she's taken advantage of. I feel that this parish development model and other wealth creation initiatives that the government is creating, if well implemented, they will actually be contributing to addressing or reducing new HIV infections. The other day, His Excellency the President talked about keeping girls in schools. We know that keeping girls in schools does not only reduce teenage pregnancies, but it also reduces vulnerabilities to HIV and AIDS. And the COVID-19 vividly showed this to us.
Thank you very much, Dr. Vincent, and I hope when we come back to the next round of questioning, you can be able to answer the AIDS Trust Fund that we have heard about and wondering why it does not kick off. Dr. Stephen, when you look at our social construct, something that you really say that really tickled the professor and I is men in leadership. What we hear is girl, women empowerment, all this is happening. So who is creating these men or boys to become leaders? That even this pillar that is here seems very ambiguous. And what does that man look like?
Yeah, you know, there's a saying that among the blind, the one-eyed is the leader. But, of course, the people can lead only when they can see where they are leading you, but if you don't know where you're going, how can you lead me to where you're going? Where you want to go? Look, we have a lot of problems here. And the other day, actually, I was in Rakai and I sat quite petrified, especially when I listened to our president mention that many of his soldiers, our soldiers, died when they are on treatment. And so when we look at these statistics, they're quite nice. 90%, 95 now actually are on treatment. So it's a question of ticking boxes. But when you look properly, these people are not taking the medicine the way it's supposed to be taken. No, treating HIV is very very tricky. It is not a question of swallowing medicine. You must swallow medicine in the right way, because a lot of people swallow medicine, by the way, and at the end of the day, they even bring empty bottles, and they have, indeed the medicine have gone through them, and those medicines have not worked. It's because they don't have the knowledge how the medicine works. We call it treatment illiteracy. Treatment illiteracy is so rampant in this country that many people, for example, during the lockdown, they couldn't even, they said, oh, you go to the nearby treatment center, and you come to Arabic, and the Arabs were there. But they just went with nothing. Some of the, when you give them a card, because of what I'm going to talk next, they tear it. They don't want evidence that somebody is treating it. When you give them a bottle of medicine, the first thing they do is they remove the cover. So when you find them swallowing, is this water or water? so you don't know. You ask them what is it? These are my vitamins. Aha. So now, when you go with the, say, ammonia ARVs, they will give you ARVs, and some people actually have their regimens, or the arrangement of medicine changed. Some were on first line, were on second line, and vice versa. So, a lot of problems. And why is this? Let me say this. It's because of the last zero he talked about, stigma. You see, if you get, let me say, a high-profile religious leader from one of the religious movements, say Catholic, and he has HIV. Naturally, I would say, you go to Rubaga. The Rubaga has a very good one. Or you're an Anglican, you go to what? To Mengo. Or you're a Muslim, you go to Chibuli. Almost 100%, none of them will go there. So now what I do, if I'm referring the Muslim, I refer them to Namirembe to Chibuli to Rubaga. I'm using that as an example. Why? The main reason is that most Ugandans, all these 1.4 million Ugandans, even if the president said tomorrow, I want to meet all people living with HIV in Uganda, you come to Korora and you know what the president can do for us. Even if they were to give us, maybe I would be one of the few who will go there. The majority will not come. Because HIV is still regarded as a disease of shame. Typhoid, for example, if you have typhoid, it's not a disease of shame. Never mind, it's a shameful disease. You get it by eating food contaminated with fecal matter. But until people have comprehensive knowledge of this disease, I don't think whatever funding we put there, and I'm in for funding, give us more money. I'm in for ARVs. I mean, by the way, we have ARVs everywhere. The stockouts you talked about are no longer there. And they are all I have the privilege, because I've been the outgoing chairman of the National Forum for Living with HIV Networks. I have all the contacts of the ART centers in the country. I go to the ministry and I call. Each time I call and introduce myself, they say, yes, we have this medicine. Call Masaf. The other day I called Masaf. Call Mugobero Health Center. Call the center in Zombo, in Kisoro. The ARVs are there. And people will not collect them. Somebody comes from Terego to collect ARVs from Kampala. There is a person here who sends his driver to Kataku to collect medicine. So this is the category of treatment. So people, if you go to the center where they're treating people who are dying of AIDS, majority of them, by the way, would be people who are on treatment. I don't have the statistics, but I think they are not people who have not been, who are failing because they are not swallowing. So we need to invest, one, in massive, comprehensive knowledge of this, of the disease, what causes it, how it is spread. This behavior change, I'm not so much, I'm not a behavior scientist, so I don't, but people say they're abstaining. Well, I would like to say that. I would like to encourage it, but many people preach water, they're drinking wine. So because of that, for me, I would treat every person as a wine drinker and teach them how to drink water. So what am I saying? We need to invest in health literacy. What is health literacy? Empowering people with the knowledge so that they can be able to make informed decisions about their life, other than teaching them how to behave. Because people will behave but I'm not, again, a behavioral scientist, but you interpret what you have depending on what you have to interpret, what you have the capacity to do things. A lot of our patients, for example, who are dying of, who have HIV, actually are not dying even of HIV. They are now dying of NCDs, non-communicable diseases, diabetes, high blood pressure. And let me say this, even mental health, which you hardly talk about, and has a problem. Many of these people who are behaving, the behavior, we say they're misbehaving, they're mentally not well. We need to assess them. Because mental health means people with mental health challenges have a lot of high-risk behavior. And then, vice versa, when people have HIV, again, mental health, especially depression, is so high among our staff, people living with HIV. Many people who are on HIV, because they don't have comprehensive packages, beyond giving them the pill, they need proper support. I pray we do invest in these ventures. We invest in training people, It's the way actually doctors are trained. Well, you cannot register in this country unless you produce evidence that you have had what they call continuous medical education. The same should be with these people who have been swallowing meds. I've been swallowing ARVs for over 20 years. But every time, I have to learn something. I have to learn something. So we need this information in local languages. The other day I was surprised when I was in Rakai. I spoke for quite some time in English. But when I switched to Uganda, actually by the time I reached Kampala, so many people had called me saying, thank you so much for talking to us. So we need to talk to people in the language they understand. I've told the people that if I could not explain something to my mother in my mother tongue, and she said, and then she said, this is what you are saying. And he says, using different words, but this is what I say, and I say yes. Then maybe I'm not understood.
Dr. Stephen, the man question.
Yes.
Because one of the pillars that Dr. Vincent has spoken about is the engagement of men.
Yes, and I'm a man, and I know men are supposed to be brave. But the face of HIV, in fact, for me, I want to meet women. They are very brave when it comes to HIV. Health behavior, they are very brave. Look, I have seen men who come with their wives and who have tested positive and they leave them in the clinic. They run away. Women, on the other hand, even when they have left their husbands, when the man is sick, they come back and care for them. So what is this? Maybe we need to talk about it. But again, we need to come up with strategies that target men. There's such a thing as male involvement. No wonder they are the ones who are dying most. But they are also the ones who are infecting the young girls most. So maybe we need to put more money into targeting them.
By doing what? What do you do for the men?
I think that's where what Semere is a prevention specialist. I think he would like to he would help me on that one. He's my name, and he's very good at it. What we do. But maybe where are they? We need to go where the men are. And when we get one who is converted, like the one in the Bible called Saul, who converted to Paul, we need to invest more in them and have more of those. I wish you could have staff men. But Dr. Semer, would you help maybe answer that question?
Dr. Agri, let me come to you. You are in the community as Infectious Diseases Institute. You are in the community. You're out there really digging in. When you hear some of the pillars that are here, as infectious diseases, as a doctor, where do you plug in to ensure that we see that this vision of 2030 is realistic and not just a fallacy?
Well, thank you for the question. I'll sort of see how to build up on my senior Dr. Watiti's comment and also build on to what we do. As IDI, or Infectious Diseases Institute, we both provide care for patients, but also support programming across the country and in different parts of the country. And this spans most of the different pillars, all the way from prevention. And prevention for the men, we start off with the circumcision. It's medical male circumcision. Yeah, we've known it. We've known that actually works. Yeah. And it's one of those unique male interventions that's not being taken very well. We've hit some dead ends, and we want to get more men circumcised. But that is one of the many things. But include the other things we do, of course, is testing. Recently, we were talking with my team, and we were testing at a building site. As you can say, building site is made of mainly men. It was incredible that out of just a good, I can't give the numbers here because of disclosure issues, but there was a considerable number of men who actually tested positive. And it made me ask where the other men we can look for. They have talked about border people and all that, but as idea, let me go back. We do have PrEP services offered by our team in Kasangati. We also support various sites across the country, of course, to to do prevention of mother to child. I would go on and on, but this is all prevention. One of the things in the HIV fight is called U equals U, which is undetectable equals untransmissible. The push is to get as many people to have the virus suppressed to a level that they cannot transmit. As one of the pains I have is that the young people who we see with HIV and who are in our treatment programs are failing to suppress. While the older persons in the 30 and above range approach maybe 90-95% suppression, among these young people we only see 50-60%, which means they're on treatment, but they are at risk of transmitting it to others. Amongst the other thing, of course, we do as we provide treatment at IDI, we have been privileged, and I say privileged by government of Uganda to be one of the units that we get money that we use to treat NCDs, the non-communicable diseases. One of the things that you notice as people grow older, they are at risk of hypertension. About 25%, almost 25 to 30% of patients who are older do have hypertension. They do also get diabetes. I think it's in the range of around 1-2%. And then also these mental issues. You talked about depression, but there's also dementia as people grow older. We have set up these services to support the Ugandans free of charge, and actually we do that. We're trying to create models that can be used and replicated. As we think about reaching 2030 with no new infections, we are likely to have, until we have a cure, we're likely to have patients who will live longer with HIV, and we must support them. So what models of care should we have? Those are some of the things we are doing with the NCD care. And the other places will also do a little more. But in addition, we do research. I can't go in there because that's another day discussion, but it's mostly meant to test out new treatments. Right now we talk about injectables. There's one which you can actually get once every 6 months, once every 2 months. There are newer medications, and these are being rolled out. We want to see how medications interact, for instance, with mothers who are breastfeeding. And there's all these nitty-gritty in the care dimensions that we give. Those are just snapshots, including looking at opportunistic infections like TB, crypto, and all that. I think I wouldn't go further in there. But to just, I would want to go back to this issue of testing. I'm very passionate about testing, and usually I'll ask the people here, when did you last test? When did we last test ourselves? For our viewers, when did you last test for HIV? It's available. Tests are everywhere. There are even self-tests, right? You can, with the saliva or oral cure, you can actually test yourself. And there's treatment. Can you imagine? You can self-test and you can access treatment. And there are places where actually you self-test. If you're positive, you actually can access treatment. We are living in that age, and I think it's time to take advantage of these advancements to get as many people tested and I think treated. There are challenges, of course. We have to support people with the stigma that comes when I think about the positive result and all. But the other point for financial, which I wanted to make quickly, is that when we reduce the infections, we also reduce the financial demand that comes with it. So one of our, I think, things we can avert is to do some some health economics of averting new infections to actually have a manageable healthcare budget for HIV, as you can think about. This is one of the, I think, things that we could prioritize as well, because with more infections, we'll have more demand on our budget. So sometimes this is one, thought that I got from my colleagues at Uganda's Commission that maybe can stimulate some thinking about it.
And the prevention, also the budget goes up because you have to prevent a lot. But let me come to...
Yeah.
It's cheaper than
It's cheaper. Actually, that's what I was going to say. It's much cheaper than
in the
treatment.
long run, it is cheaper.
Okay.
Yeah.
Because when you prevent, then you are not increasing on the number that you have to give.
Exactly.
to good treatment.
Dr. Francis, let me come to you. A lot of research, a lot of things have been done by JCRC, but we also see genotherapy that has been spoken about a while. Injectables have already been spoken about. How far with, other innovations to come in here to support, to suppress the viral load there, but also to support the people to be able to be interested in the testing because they know there is treatment there? Genotherapy is one of those things that could be a win for us.
Yeah, sure. These are actually highly specialized packages. But before I actually talk about them, I would like to re-emphasize, I've been listening what Dr. Agro was saying. I like thinking simple. I still believe in prevention being better than cure. I was having a discussion with one of my colleagues at JCRC, and we're discussing about children being in boarding schools and having to have them tested for HIV. Because the truth is, you cannot treat what you do not know. Like, we need to know that there's HIV and then we treat. And then there was this hot discussion about parents' rights, you cannot test my kids, all those issues. But like Dr. Agri has said, there's treatment. When did you last test? I think everyone has a role to play here. Dr. Vincent talked about the different strategies the government is doing. We've talked about the funding agencies. There are all these public health interventions. But you, the individual, the Ugandan, what have you done to have an end to HIV? And the strategies are really very simple. Test, treat, okay? There are all these other prevention packages he talked about. He talked about safe male circumcision for male. Research has proven to us that this can reduce your risk of infection by 60%. That's quite something. Me, if I remember in school when you got 60%, you had passed. I mean,
Even at university you passed.
Even at university, I know at my master's, the pass mark is 60%. So we are thinking abstract, yet they are the simple things, the simple science that we already know that can help us have an end to HIV. Simple things like consistent, proper condom use. Protect your partner. I mean, if I do not know my status, especially for discordant couples, why don't you use the condom? Those are simple, simple things. And we've been singing these things for over years. It is talked about PrEP. PrEP is a pre-exposure prophylaxis. We've done a lot of research, and we know that these are modalities that can help us prevent HIV. Okay? Dr. Watiti has been talking about proper use of ART. It's not just, when we say there's ART available, there's availability of drugs, but the proper use. Are you swallowing on time? What is the half-life of the tablet? How long is it protecting you? I mean, what happens if I missed a week? Like, you go for a trip, you go up country for a few days, you miss because of, stigma. Like, are we understanding why I have to swallow every day? I remember when I used to work at Baylor, we had, like he mentioned, we had these children, because we had this technique of pill count to assess adherence. And all we did was to count our pills. Like, we gave you 60, pills for 2 months, so we expect you to come with nothing, empty bottles. And you know, the kids would just empty these bottles and come with bottles. You see, we also had transport refund on every visit. So a kid knew that, I mean, if you didn't come with empty bottles, there would be challenges with, you know, getting your transport refund. But are we educating them enough to understand why they are taking their medication on a daily basis? So those are simple things. Let's think simple, simple science. She's an expert in social behavior, you know. She's talked about it. So some of the things that the parents need to talk to these children to differ from, you know, sexual activities. I remember me, I have a Chiganda background. I remember when we were kids, if you did something wrong, for example, if you ate your meat before your food, your mother would just look at you, that eye from the mother, and you know that when the visitor goes away, and these are some of the things parents can do for the children. Like now it is holidays. These are some of the things, but you see, because of social media, people on phones, people are leaving the children with maids. So we are thinking abstract, but there are these other simple modalities that are very practical, that are cheap, that we can, you know, venture into and, you know, prevent HIV. So I've not yet answered your question. To go to the specialized care, yes. It talks about the injectables, yes. Clinical trials are still underway. You see, the good thing with medicine is before we avail you with treatment, we need to be sure that it is safe. Okay? So we know there's science that all these injectables that are you can swallow, and then your viral load will be kept undetectable for some time, and then you until you return. But you see, all these are still being, you know, looked at. How safe are they? There is a care study at JCRC. I do not want to go into the details, but all these are coming. But still, there will be individuals that will abuse them. So even when they come, I still think we need to still think simple and educate everyone well for every modality that came. There's a paper I'm writing. No, it's actually a publication that I'm thinking about writing. I don't know whether it's a convenient environment to discuss here.
You tell us the findings. We're not going into this.
And the watered down findings for this.
I'll save that for another day. But yeah, there's research, there's a vaccine research. We've talked about gene therapies. Gene therapy, in simple terms, they just modify your genes to have a cure of the disease. The team at JCRC is collaborating with the teams in the Western world, Asia, India, to have these available. But like I mentioned, these are highly very specialized. And if you look at Uganda and its problems, these are modalities that probably very expensive, that might not benefit my parent or my children down there in Chisoro. Okay, so but they are good to, you know, look at. So that we're looking at new drugs for drug resistance, HIV. There's research being done to have these available, because when you see the adolescents, like she will tell you, the adolescents are very tricky. Like, you will avail them with all this beautiful medication, but because they are adolescents, we have issues with adherence, and we're having a lot of resistance. So scientists are thinking of having these medicines that can target this resistant HIV.
Thank you very much.
Moderator, really, I like him. The fact that he's simple, and although he's very academic, you see he's writing papers, but and I want to jump in because he mentioned the issue of dementia. As you grow old, I might forget this. You see my age. But really, we need to normalize this.
Yeah.
If, for example, in the company, a person comes in shivering with headache, and you really don't test them for malaria, if you should commit, it is criminal. Now we know HIV is a human immune deficiency virus. Never mind the way we understood, we thought it was a gay disease. Then later on we think it affects people who are bad-mannered. So these people respond by saying, we are not bad-mannered, so we don't have the disease. So we have this problem. For example, when you tell people that, you people, you behave properly, so that you don't get this disease. Without saying, you are saying, don't behave like Dr. Watiti. And so I said, who told you I behaved badly? So I keep quiet. And yet we know, for example, testing is the only way you can find out whether you have this disease. And when you have the disease and you put upon treatment, then they don't even fall sick. Even when they were very sick like I was, they stopped being sick. I haven't been sick for over 15 years. And yet I had AIDS. So, and this is the information we need to give these people. So now the question is, why would, for example, a human being, because we know HIV is a human immune deficiency virus, a human being walks in a health center, they remove blood, they test all other things, but to test for HIV, you have to say for permission. In fact, if you test somebody for HIV, they take you to court. So this is where I'm wondering. And we really doing things the hard way. Why don't we simplify? If a human being comes and we test for blood, for HIV, we don't have to seek for permission to tell them that we have found HIV. So we created this problem, especially with the medical. You know, when we started, we say HTLVI something. When they ran that, we say ISSS. We change the names until now we have run out of the names.
I've gone back to HIV.
Even ask people living with HIV when they say we have AIDS, that is, they call us all sorts of names. But what I'm saying is this: we need to act simple. The human being comes to a clinic. We would talk to them certainly and say, look, the way you are behaving, you are a human being, whether you are a priest or an MP or a doctor, you are a human being. So we find HIV, we put you on treatment, we suppress the viral load. You can go and misbehave, but you cannot transmit this virus. That's what I really would like us to do. Unfortunately, there are laws, and the other day I was talking about laws, which are, and then also everyone jumps in with their, we doctors thought we were the right one. Now the social scientists have come in with their own. This one's coming in. So we have complicated things. I really love my young colleague. Let's be simple. This disease could be one much faster than, but the way we are behaving, unfortunately, and we may reach 2030, it will be here, which is very unfortunate, because for me, I was hoping I would be in a group that goes to Kololo to celebrate the last person infected with HIV in Uganda. But at this rate, I don't think we are going to beat.
Okay. I hope the cloud of hopelessness can be built by hope here. Professor, let's get back to the social construct, and especially with the young people. This message is good. How do we deliver it in a package that fits them, a tailored message for them? How do we build our social construct?
Thank you very much. Actually, the more they spoke, the more I thought they needed to appreciate the social. You know, Dr. Watiti is saying he thought the doctors knew it. But I think if you're honest with yourself, the previous interventions that worked were not entirely medical. They were largely social. We only went down on the social because we thought now we had treatment. Okay? So the thing then migrated into a biomedical model. But the thing remains largely a social disease, driven by social drivers. So medics are not the only experts on this matter. So we need to work together. So the medics provide the expert knowledge, and the other people know what to do about it. So I think we need to appreciate that and continue working in that way. That's right. Before I come to what we do with younger people, you had also asked something about men. Indeed, not all men are bad. That's where we need to start from. There are some men who are doing a good job. Most of the men who report defilement, people who report defilement on communities, people who report sexual harassment in higher education institutions, will actually be male. They provide the support that enables these women to come forward. So men have been very good partners in some of these vices. And indeed, we do have, like at the School of Gender Studies, we do have programs for men. We target actually positive masculinities And how do we promote that in a culture which is dominated by a macho masculinity, counted by how many women you have slept with and how many people you have beaten? There are many men, the majority of men are not doing those bad things. The only thing that the bad guys are the more prominent, and then they set the pace for everybody. So we have some of the projects like dealing with the less toxic masculinities. We have actually projects in different parts of the country in where there's violence, for example. How do you make males less violent? And these projects just deal with men, and we just work with men, and they appreciate them. Before the previous French ambassador went, he and I think the UNDP, UN Women, both, Maxime, they were all men. They had come up with a project where they were dealing with males at corporate level. How do they make a contribution to reversing negative gender norms? Okay? I know the rest have gone, but at least I know one of the members of that group was Mr. Robert Kabushenga. I hope he's still carrying on the matter because it's a men's club, but organized for positive against negative gender norms. We have men in so many groups, whether in the police or whatever, trying to do something about making men more responsible and getting men as allies to fight against these things. So these I think the issues, we don't hear about them because they don't amplify themselves. So probably we need to amplify them more than amplifying the bad guys, because those are the ones you hear about from the press. But there are many people doing a good job. So you're talking about how do we get younger people on board. The first thing is what they've said, ending stigma. We've seen younger people who cope very well at home. When they go to boarding school or they come to university, the peer pressure makes them stop taking the medicine. And some of them, we have lost them at a very young age. So stigma is everyone's problem, whether old like us or younger people. So that's one thing. The other thing, as Dr. Watit has said, people need information. People need health literacy. People need to know about HIV. And that involves knowing about the disease, what it can do to you, and how to prevent it. Because we see that since there's treatment, people have gone down on condom use. If you have to behave in a certain way that is reckless, at least remember that the government has provided condoms at a cheaper cost. He talked about PrEP, but also there's PEP. We work with generations of younger people who talk about things called debt rape, and indeed it occurs. But it is a hassle getting them into PEP, okay, the post-exposure prophylaxis. And like in Makere, for example, we have the sick bay has these things very, very available. But you see people come and tell you a story of then this happened and this happened, can we go there? No, then they don't want to go to. So it is a struggle, and as he said, you don't force people into care, you only counsel. And people should be willing to go into care. Another thing that can happen to younger people is something like, you know, we talked about the Twitters and the rest, finding them where they are. But you know how we are all on our phones and websites, and things keep popping up that you haven't. So probably we need to make these things pop up. The nuisance, but the information will be good in a long time. So we need to do that. But also, I think as the younger people come on board, those who deal with them, it's very, very important that they come on board. But largely we have to deal with positive masculinity and to also deal with peer pressure. But the other important thing, we need to stop blaming females for things which come out of risky sexual behavior.
That's right.
So you find when a girl gets pregnant, you blame her for, even if she says the teacher, the question is, why didn't you say no? When a family has HIV, the first thing is women have killed us. So for a long time, anything that goes wrong on the sexual front, these women are killing us. Even when you tell the men, why don't you be responsible? But then she was beautiful. So sexual issues have always been constructed as women's issues. Maybe that's why you find a lot of programs of empowerment on that line, and men are being left behind. So if we see that these are everybody's problems, a woman can say no, but also a woman can be raped. So then you cannot blame her for that. So I think let us see this as everyone's problem, and then we deal with that. But lastly, okay, two last things, which I think should be very important. We've talked about the PDM. Pillar 6 in the PDM is about a parish-based management system. And we talked here about the people who are in care are not the ones who are transmitting.
That's right.
But we have very many unknown. And I know the PDM is largely around getting us out of poverty. And in the past, HIV, AIDS made it possible for us to know where everyone was. who had a problem. So if PDM goes, I know it is still early days, but we need to actualize that pillar. We've been talking about actualizing that pillar for agriculture, so that you know which home has 2 chickens, which one has 4 cows, which one has, so that government can do very good intervention. Which home has which kind of acreage, how do you get them together to grow certain things? So if, as Dr. Watiti has said, everyone's going to a facility for malaria, and I know if you go to health facilities, you get this information there. This one came on this day, was this age, was female or male, came from that place. So the health facilities are doing that. So if they collected that data plus other things, and maybe in the parish we knew, not for stigma purposes, but for support purposes. So we need to work together how actually that parish-based information management system is going to work. And I think lastly, in addition to knowledge, there has to be incentives for people to behave better. And the incentives, in addition to knowledge, you need to be able to actualize, to enable people to practice good behaviors. And one of these is to reduce the toxic things in society. Of course, already we have treatment, so that reduces on the infection. That's on the medical line. But we have to do something about people who are behaving badly. Okay? I know in the past people talked about how to deal with the defilers. But now we seem to have gone more in the mode of negotiating. Your child is defiled, and then a goat is given, and because goats are cheap, so defilement is okay. You can easily sort it out. But I think we need to reflect on some of those things, because they did help in the previous case. So that at the end of the day, the incentives are there. Of course, some of them are economic, like some of them are material. The medicine is there, so you take it, swallow it. If they're saying they cannot swallow it because they don't have, that's on the economic front. But also the other things, the social, as people say, if Dr. Watiti is going around and saying, I am a doctor, but I'm also living positively, that can be a way of encouraging someone else to do something. So there are things like social reputation, which if we rewarded people who are coming out, then that becomes an incentive for other people to come out. But also there has to be the moral. Like Dr. Watiti has kept saying, what kind of man does that? Those are moral questions. What kind of man does that? What kind of woman does that? So if people can reflect on who they are in society beyond the physical, then that will be a good thing. Thank you.
Okay. I'm going to request, because of time, I'll start with Professor. I'll give each of you 2 minutes to give your parting shots. I'll start with Professor, and Dr. Francis, Dr. Aggrey, Dr. Stephen, and finally, Dr. Vincent. Professor.
Yes, thank you very much, Timothy, and thanks a lot, everyone. I think, one, I want to commend the medical forces in Uganda who have worked so much, of course, blessed by the Uganda government, to work hard to reduce HIV from the figures that were in the 1990s up to now. We had worked so well, but now we are worried with what's coming up. But for what I think is, we have over-medicalized HIV. HIV is very much a social disease driven by social drivers. So we appreciate the treatment and care, but that should not make us relax. We also need to do something about it. But as has also been shared, understand the demographics of the population we are dealing with. It seems to be a fearless generation. It has a lot of information. In addition to expert doctors, we also have Dr. Google. So once Dr. Google has told you something, you don't care what the physical doctors are telling you. So we need to know that this is an age with an information overload. So the medics have to work faster and be above that. I don't know how it will be done. But largely, given that it's a social disease, everybody has to come back on board and play their part. Thank you very much.
Thank you very much. Dr. Francis.
Thank you so much, host. Thank you, viewers and the listeners. To me, I still think that much as everyone has a role to play, you, the individual, the Ugandan, what have you done to stop the new infection? Because our challenge right now is the new infection. And if we can eliminate, if we can reduce to zero the new infections, then we are into the right direction. So what have you done, you as the Ugandan, the individual out there? My message to you is think simple. Like earlier on I discussed, think simple. Let's do what we can. There are a few modalities that we can do that are very cheap, are readily available. Things like condom use, things like safe male circumcision, things like PEP, things like PrEP. To me, I still think those things are readily available and they're very cheap. We can use them.
And just one thing, when safe male circumcision came up, there are some Christians who believe that's a way of Islamicizing the country. So they end up going against safe male circumcision. So as you work, that's something you should pay attention to.
Surely.
Interesting.
Yes.
Dr. Agre.
Yeah, I think achieving, knowing most of our people's HIV status has been achieved, has been done in countries that are close to us. Rwanda has done it, Tanzania has done it, and we can go on, even Botswana and Zimbabwe. I think even us as Uganda, we can. And it's very important. The only thing I will call on every one of us, let's not get scared of testing. Let's just not get scared of testing our HIV status. Test as much as you want. Come to us. We are friendly people. We shall walk with you. We have walked the journey with many, and we are still walking with many. And we don't get tired. That's what we were called in this world to do. And we are ready to do it with the hands on deck. We shall work with others, and I appreciate the social dynamics, and we know that there are challenges in there, but we are ready to stay the course and stay in the fight.
Thank you very much. Dr. Stephen?
Yeah, I think, like I said at the beginning, we have done a lot. We have done a lot. We have identified most people. But as it were, towards the end, it becomes a bit more slippery, but we could do it even faster now that we have the tools. I know there is fear, naturally, but I want to encourage everybody to have health-seeking behavior. Go for medical checkup. Medical checkup include an HIV test. So when you go for any health center, actually in Uganda, can test for blood pressure, for diabetes, just even checking your weight is good enough. And then, while at it, since we are having a problem here and we don't know where the 100,000 people who have this disease are, test. And when you test, don't live in fear. There is enough evidence that you can live a normal lifespan and even be more productive than otherwise if you know your status and do the things that we know work, like taking ARVs. In fact, for me, if I were to pick one of these, I would say, if we got all people and put them on ARVs, one, they will not die, which most people fear, which is the biggest source of stigma. But then they will not transmit.
That's right.
So you can behave, and I'm for abstinence and being faithful. But in case you have challenges in that area, even if you did that, you cannot transmit HIV because you cannot give what you don't have. You is equal to you, and take the words Dr. Semere said, and it is untransmissible. Thank you.
Thank you very much. Lastly, Dr. Vincent.
Yeah, and I think I'm not tired to also say test. Testing for HIV and is the entry point for all the other HIV services. If you are negative, still there are services that you will benefit from.
That's right.
If you are positive, then you will enter into care, access antiretroviral drugs, which are readily available. But also, the other thing I want to say is every time you have unprotected sex with a person whose status you don't know, even if you had tested and you are negative, your negative HIV status expires there and there. You must look for...
Go back and
you must go back and test. And I want the young people to appreciate this. It's a very important point, that every time you are maybe excited out there in a happening place or whatever has happened, a moment you have unprotected sex with a person whose status you don't know, yours expires there and then, and you must go and do another test. And the last but not least is prevention is better than cure. Young people, HIV is real. If you have unprotected sex, the risk of transmission is still real. And I can tell you that when you become HIV positive, it means that there is a cost involved. You may not be the one meeting the cost, it's the government, it's partners, it's whoever, but there is a cost. But beyond the cost, it takes an effort for you to be on treatment. So yes, treatment is there, we can provide it, but the best thing is to avoid getting infected in the first place. So abstain. If you have a partner, be faithful to that partner. And if indeed you can't be faithful to your partner, use a condom. Condoms are everywhere in this country. Use a condom. We have also, of course, had beyond the condom that there are drugs which we give for prevention. The pre-exposure prophylaxis and even the post-exposure prophylaxis in case an individual has been raped or a health worker has had a prick. We can give you medication, and that will minimize the risk of you seroconverting to HIV positive. So this technology is there. Really, young people, and even as the adults, let's take advantage of this technology and prevent new infections.
Thank you very much, gentlemen and lady. Thank you for coming through and gracing to be able to discuss such a pertinent issue, especially on our fight of HIV and AIDS to a target of 2030 as a country. Zero to stigma, to infections, and to newborns there. We need to be part of this fight. It is not just for the gentlemen that are here or the medical workers. Religious leaders, cultural leaders need to come and be on board with this fight. Young people out there, let's live responsible lives. We'll end this with this quote. We're not what we know, but we are what we are willing to learn. We're not what we know, we're what we are willing to learn. Good morning. God bless you.
Meet Brian Namanya, a visionary and a game changer whose team at Tubayo is breathing new life into domestic tourism. By curating exciting yet affordable experiences for Ugandans and foreigners to enjoy, with the help of technology, Brian is showing us all the immense potential out there. Those who know Brian know him as a serial entrepreneur who's always been challenging the status quo and won't stop now. Brian, we're in your corner. You are unstoppable. MTN, the Unstoppable Network, celebrates you. Visit www.tubayo.com and together let's support Ugandans like Brian who are driving our country's unstoppable progress.
UBC, inspiring Uganda. UBC, inspiring Uganda.
Over 1,000 children with disabilities in Uganda every 5 years have not had access to adequate education. And this has been basically due to lack of assistive devices to enable them get reasonable accommodation in schools. Mokisa Humanity and Inclusion Foundation is leading a campaign to fundraise for assistive devices for 500 children with disabilities to get in school in the year 2024. Join us to fundraise for braille machines, slates and styluses, white cane, braille paper, hearing aids, wheelchairs, audiobooks, book recorders, JAWS software, among others on 10th December at Hotel Africana. Register your child with a disability by calling us on 0740 55 04 95 or 0783 91 11 14. Donations from well-wishers are also welcome. Entrance is 100,000, 150,000, 200,000 and a table goes for 1 million shillings. This is sponsored by UBC, Mokisa Inclusive Schools, Mokisa Nasaran Primary School, Herona Hospital, Msafiri Tours and Molia Foundation.
UBC, inspiring Uganda.
In this footage here, the skies above were painted white, blue and red, and the streets were lined with the two countries' flags marking Vladimir Putin's arrival to the UAE presidential palace. In some of his first remarks, the Russian president outlined bilateral cooperation with the country.
Thanks to your position, today our relations are at an unprecedented level. The UAE is Russia's main trade partner in the Arab world. Last year, the trade turnover rose by 67.7%. It will be even larger this year, I think. The same goes with investments. We conduct a number of large oil and gas projects. We also cooperate in OPEC+. We cooperate in the international arena. The UAE contributes a lot in stabilizing the situation in the world, being a non-permanent member of the UN Security Council.
If anything has seeped from behind the closed doors of the palace, you can probably still make out in the background over there, very beautifully lit up against the night sky of Abu Dhabi. But if they were anything close to what we've seen when Vladimir Putin arrived here to the capital of the UAE, well, certainly, those news would be breathtaking, as were the views, because when jets painted the skies in the colors of the Russian flag, when the motorcade of Vladimir Putin joined the escort of cavalry, and the streets were lined up by Russian flags again, and the Russian national anthem sounded right before the talks began, well, those pictures were certainly a bitter pill to swallow for anybody who were advocating for the version that Russia has been sidelined, that Vladimir Putin has become an outcast, that he has been shoved to the fringes of international diplomacy. And well, both Vladimir Putin and his counterpart here, they have stressed how close the ties are between the countries. After all, the UAE is the major economic partner for Russia in the region. If you take oil trade alone, last year the increase was in fact more than 100%. So it certainly seems that Russia has figured out the answer to the equation and to the challenge that is posed by the Western sanctions, which have been trying to cripple Russia's energy trade and Russia's energy markets. And all these warm words, they have been reciprocated by, again, the counterpart of Vladimir Putin here in Abu Dhabi.
Relations between the Russian Federation and the UAE have a historical character. In recent years, relations have been actively developing in various fields in the interests of both countries and peoples. I would like to emphasize that I very much appreciate your personal and effective role in strengthening bilateral relations. In this regard, I would like to say that the UAE is Russia's largest trading partner in the Middle East and the Gulf region, and I will be happy to continue our joint work to strengthen bilateral cooperation in various fields.
Well, these pillars, these historic pillars, they provide a fantastic foundation for Russia and the UAE to grow their relations, I have to say. After all, remember that the UAE was invited to join the BRICS alliance, which has already seen some expansion this year, and, well, the UAE might be a very welcome member here, given that Russia has been nurturing this baby, nurturing this economic and political bloc from its cradle. And by the way, another country that Vladimir Putin is in fact right now is en route to, Saudi Arabia, received a very, very similar invitation.
As Gaza has been the site of widespread devastation, the Palestinian Authority has called on the United Nations to stop Israeli aggression, calling its actions organized terrorism. It comes as Israel says it has reached the heart of the southern Gazan city of Khan Yunis, saying it has no intention to stop there. Reports said that at least 40 Palestinian civilians were killed in the latest Israeli airstrikes on the site of Khan Yunis. Attacks on southern Gaza have ramped up despite it being a so-called safe zone. The UN has cited Israel as saying it has conducted more than 10,000 airstrikes since the start on the 7th of October. And the UN has said there are serious concerns about whether Israel is complying with international humanitarian law. We spoke with survivors in Khan Yunis.
I don't know what happened exactly. There was an explosion and I was hit in the head by the shrapnel. I immediately threw myself to the ground.
We were sitting and suddenly a strike hit, and I was struck on the head by a falling stone.
My sister had 8 children. She fled from Man during the bombardment and took shelter here. And as nearby areas were being hit, she had a seizure and died of a stroke. She's survived by 8 children, and their father is displaced, trying to make a living.
An apocalyptic situation. That's how UN Human Rights Commissioner Volker Turk says his colleagues described the humanitarian conditions in Gaza.
My humanitarian colleagues have described the situation as apocalyptic. In these circumstances, there is a heightened risk of atrocity crimes. Measures need to be taken urgently, both by the parties concerned and by all states, particularly those with influence, to prevent any such crimes.
Here we see people in the city of Khan Yunis grabbing what they can from the United Nations aid warehouse. Many rush to get even the basics, with drinking water in high demand. We heard from Marta Lorenzo of the UN Relief and Works Agency for Palestine. She said there is currently no safe place in the Gaza Strip.
What I can tell you is that the situation is desperate. We are seeing more people being killed, more our installations, UN installations being damaged, more displacement towards nowhere. In fact, there is no place in Gaza that is safe. Al-Mawasi is a very small area in the southern part of Gaza. It's the kind of sandy terrain where there is no infrastructure, there is nothing there. It is very difficult to settle displaced people there or to provide assistance in such a place. This is not prepared to receive massive displacement like the one we are seeing. In fact, what we want is protection for our own installations so that we can provide humanitarian assistance, that they are protected, that they are not damaged, and that we are able to be granted access to people wherever they are. Safe zones need to be agreed by all parties in conflict, and this is not the case right now when we refer to Al-Mawasi, and of course the minimum conditions for a safe zone to be there need to be established. Al-Mawasi is an area where it's desertic, there is nothing there. It is very, very difficult to all of a sudden shelter thousands and thousands of displaced people. This is not possible. This is different from what has happened in other conflicts, because to start with, people in Gaza cannot flee anywhere. So they are staying in a smaller and smaller area as displaced population. It's not that they are not able to return to their country. They are within the territory where they used to live, but they are not able to return to their homes for many different reasons. The first and most important is safety and security, because as violence and bombing continues, it is not possible for them to return.
Israel says it has installed at least 5 water pumps that it could use to flood Hamas's vast network of tunnels under the Gaza Strip. The water for the system would come from the Mediterranean Sea. The IDF also says it could blow up the tunnels with bombs.
We have various ways to deal with the tunnels. I won't talk about specifics, but they include explosives to destroy and other means to prevent Hamas operatives from using the tunnels to harm our soldiers. Therefore, any means which give us an advantage over the enemy that uses the tunnels, deprives it of this asset, is a means that we are evaluating using. This is a good idea, but I won't comment on its specifics.
The pumps would theoretically send thousands of cubic meters of water per hour into the tunnel networks, with the entire underground labyrinth to be completely flooded within weeks. It remains unclear whether the Israeli government is actually ready to conduct the plan. And while environmental experts demand that Israel adequately consider the long-term ecological impact, there are also concerns that the flooding could undermine the structural integrity of the buildings on top of the tunnels.
It's hard to tell what pumping seawater will do to the existing water and sewage infrastructure. It's hard to tell what it will do to groundwater reserves. And it's hard to tell the impact on the stability of nearby buildings.
Let's cross live now to former senior U.S. security policy analyst Michael Maloof. Sir, thank you so much for joining us today on RT. Now, we're talking about these tunnels. The IDF has apparently been planning to flood the tunnel system to trap any Hamas militants within them, or perhaps force them to leave. What do you think about this plan? Is it a good strategic plan? And what about the hostages, by the way, if there are any in there?
Well, all the questions you raise are very, very serious. It's my understanding that there has been a beginning of some flooding of tunnels. It's an unconfirmed report. Now, what I think is happening here is that if you do that, you absolutely make the land inhabitable. You undermine the water systems, the infrastructures. You can't grow crops, and over the long term. And it's very intriguing because just today, I was shown a newspaper headline from a Jordanian newspaper from 1970 that said that the Israelis wanted to clear the Palestinians out of Gaza altogether. This is a way to do it. If you make that area totally uninhabitable, they have no place to go. But that seems to be their mission right now, is to ultimately corrode everything. The salt water, it's salt water from the Mediterranean. I've experienced it even in Lebanon. It's very salty. It corrodes. It also prevents any growth of crops. Farmers would be devastated, and their fresh water systems would also be affected. The whole mission, I think, of the Israelis at this point is to make the area uninhabitable without saying so. But that's going to be the effect with this approach, and it would be disastrous. But who's going to stop them? And they've already confirmed that they brought in pumps to pump in the water. So this is going to be a whole new turn, because then the question is, where do these Palestinians go? The Egyptians don't want them, and all that the Israelis care about is that the Palestinians just get out. And again, I think they're treating Palestinians like they're subhuman, and this is an outrage.
Michael, that's a catastrophic analysis. We've not thought about that. Absolutely, you're absolutely right. I mean, if you look fast forward, even when this is all over and there's a ceasefire and they try to rebuild on what? I mean, the soil
do
will
it.
be absolutely soaked. There'll be no crops, as you said. This is the end game, isn't it? I mean, and to answer your question, maybe perhaps the Palestinians could reclaim some of the Israeli land that was stolen. Is that an option?
If the Palestinians wanted to come in, but it's clear now that the more radicalized Zionist regime does not want Palestinians. They want a pure Jewish state, and that is reinforced by the settlers, who are even more radicalized. Look, this government doesn't want to stop this war. They want to go all the way to Iran. They've made that very clear. And that helps preserve Netanyahu. That's the whole end game here, is for Netanyahu to preserve his government politically and personally at all costs. And this is the way to do it. But who's going to stop him? Who is stopping him at this point from this game plan? You can see this plan emerging. They don't have to say it. We can see it.
Michael, it's really disturbing to hear those words, but you are right, indeed. You know, when we think about it, of course, the U.S. backs Netanyahu every step of the way. They're too scared to do anything else. People call it the 51st state. But they are not the only two countries in the world. There are over 190 other countries. Can we not see these close to 2 million Palestinians being some sort of, I don't know, they're hostages, in fact, in their own country, but will the international community not stand up for them?
Well, they haven't until now. So what makes us think that they're going to do it now? I mean, I have been to Lebanon. I have visited the Palestinian camps there. They are so crowded. They're overcrowded. And yet, nothing happens. So what happens with them? We got camps in Jordan, refugee camps. Where do they go? They have no place to go now. And Gaza, and of course there's West Bank. That's going to be in turmoil here very shortly. So who's going to stop this trend by Tel Aviv to carry on and basically do a methodical extermination, basically, of a people? This is what is occurring here, and it's tragic. And no one, and the UN is. It is useless to get people to come together and try to work out a plan to make this thing, to try and quell this. But again, Netanyahu's in charge. The United States is backing him. I just hope that the U.S. Congress fails at this point any further approval of any appropriations for Israel, because that's what's going to keep them going, and that would tacitly show U.S. support. Basically, what Israel is doing to itself, and in turn dragging the U.S. into this, is isolating both countries in the world. This is what we're seeing, and with the creation of a multipolar world order that's emerging, and you referred to the BRICS and what have you. This is what is emerging in response to the U.S. unipolar-led world order.
Yeah, very well said indeed. It is a tragedy indeed. Michael Malouf, we're going to have to leave it there. Former senior U.S. security policy analyst. Thank you so much for your time.
Thank you.
Over to the U.S. now, where President Joe Biden has hinted at the possibility of American and Russian troops facing off in the future. This is as he urgently warns Congress that further financing for Ukraine cannot wait. A vote on the topic is about to take place.
Putin attacks a NATO ally if he keeps going, and then he attacks a NATO ally. Well, we've committed as a NATO member that we defend every inch of NATO territory. Then we'll have something that we don't seek and that we don't have today. American troops fighting Russian troops. American troops fighting Russian troops if he moves into other parts of NATO. Make no mistake, today's vote's going to be long remembered.
While tempers over military aid are flaring at the U.S. Senate, Ukraine has also been losing supporters in Europe. The German defense minister has gone as far as to claim that Berlin is not an ally of Kyiv. Russia's foreign ministry spokeswoman pointed out that's a complete U-turn for the German official.
German Defense Minister Boris Pistorius said that Germany is not an ally of Ukraine. Boria unpacked the new loafers he had been given last Christmas and changed his shoes.
Meanwhile, seeking further military support, Ukrainian officials have arrived in Washington for a series of meetings. That's after the U.S. Defense Secretary has reportedly gone so far as to threaten the Congress with sending American troops to Europe if more aid for Ukraine doesn't get approved. The House Foreign Affairs Committee chairman echoed that sentiment.
If Putin takes over Ukraine, he'll get Moldova, Georgia, then maybe the Baltics. And then the idea that we'll have to put troops on the ground, in Secretary Austin's word, was very likely. That's what we're trying to avoid.
Let's discuss this further. Joining me now is former U.S. military officer Scott Burnett. Scott, thanks so much for joining us. What do you think about the U.S. Defense Secretary reportedly threatening to send more American troops to Europe if Congress doesn't approve further aid for Ukraine?
Well, I've just been to Ukraine and, well, I should say Russia. I was just in Russia for 3 weeks. And as you may know, I was in Mariupol, I was in Soledar, I was in Zaporozhye, I was in Donetsk. And what I saw was nothing short of war crimes and crimes against humanity that were committed by the United States and Ukraine. The United States weapons and money that have been given to Ukraine have tortured and tormented the people of those areas. And let me tell you something. I will be making a very loud and passionate decree of the findings and the videos and the pictures that I obtained when I was on the ground in the Donbass, when I was wearing body armor and I was among the volunteer troops from every part of Russia that were fighting the Ukrainian Nazis and Bandera fanatics. I will be presenting that to the United States Congress and various other elements, including Lloyd Austin and the White House, because what I saw in the riddled buildings and the shattered windows and the ruined lives and the crosses for the children and others and old people that have suffered in Donetsk in particular, it is an abomination which the United States has committed, and NATO. And I think that's why these countries are turning very quickly. What they anticipated would be a silly utopian dream of thwarting Russia and overthrowing Putin and a color revolution. All of that nonsense has failed to come to pass. But what has come to pass are crimes against humanity that I saw. And it was the Ukrainians that committed this, not the Russians. I was deeply moved by the passion and the professionalism of the Russian volunteers in all of those areas. But I just got back yesterday from Russia, and I'm still decompressing. So, yeah, I feel like this entire thing has been a personal experience for me, too. Because when you're on the ground, when you're having weapons fired at you, when you're having artillery shells fired at you that have been financed and that are the United States artillery shells trying to kill an American citizen, you get a little bit perturbed about that. So I'm perturbed by what I saw. I'm infuriated that the United States Congress is either so corrupt or so stupid that they continue this nonsense of backing and financing Ukraine. And I think a lot of Americans are waking up. I will guarantee you that every congressman and senator that I communicate with will never forget the communication that I engage in with them, because it's up close and personal. I was there. No American except me has been. Certainly no congressman, no Department of Defense official, except those who were helicoptered out of the Azovstal plant and other places of Mariupol. But all of this, I think, is coming to an end. That was one of the things I tried to impress upon the Russian soldiers who had been wounded in hospitals and elsewhere. The American people do not back this war. The American people do not back Zelensky. They do not back Nazis. They do not back swastikas being carved into young women's bellies by Ukrainian fanatics. They do not support the extermination of the Ukrainian population by Zelensky. The Americans have just been sorely ignorant of this. But I think to sum it all up, this is Lloyd Austin and McCall and Lindsey Graham, the warmongers, trying to scare the Republicans into giving money, or else American troops will be on the ground? Nonsense. Not only
Scott,
could not one single American
I'm going to have to thank you and stop you there. I'm so sorry. We have run out of time. I really appreciate everything you've said there. Thanks again for joining us.
Thank you.
Well, that wraps up this news hour. We'll be back in just under 30 minutes with the latest updates. Join us then.
And welcome to Crosstalk, where all things are considered. I'm Peter Lavelle. Kiev's woes only seem to increase with each passing day. Its counteroffensive was an utter failure. Continued massive Western support is in doubt. Zelensky's popularity is on the decline, and the military essentially has few ideas how to proceed. Kiev is running out of options. Cross-talking Ukraine, I'm joined by my guest, Dmitry Laskaris in Montreal. He's a lawyer and a freelance journalist. Also in Montreal, we have Michel Seymour. He is an honorary professor of philosophy at the University of Montreal. And in Paris, we cross to Vladimir Goldstein. He is the chairman of the Department of Slavic Studies at Brown University. All right, gentlemen, crosstalk rules in effect. That means you can jump anytime you want, and I always appreciate it. Let's go to Vladimir in Paris first. I'm titling this program "Regime Collapse?" here. We have a number of articles coming out in the mainstream media talking about the popularity of Zelensky, or the lack thereof, how he's having a pitched battle with his military, particularly with General Zaluzhin, and also the ever most important element in all of this is Western aid, which some of it will definitely come through, but not nearly as much as they were all hoping. So just how unstable is the regime? Because if the money goes, then it turn off the lights. It's over. Vladimir.
Well, both regime is unstable because it was running primarily on Western help. But what is absolutely clear, and that the narrative is totally destroyed. It was like a very convenient narrative. Bad Russia, autocratic Russia, democratic Ukraine, and Russia wants to kill the young green shoots of democracy in Ukraine. Well, we see it's not democracy. It's not a booming economy. It's a country which catches men up to the age of 60 and sends them to butchery. They're not quite ready for that. The only thing they were ready is to get NATO equipment and send it in the front. Even this one is stopping. So we see the real sort of collapse of the narrative that Zelensky is a great leader which is going to liberate not just Ukraine, but would lead to sort of liberate Russia from its autocrat and so on and so forth. So it's not happening. And I think what is fascinating about the whole thing, since Zelensky was so much vested with this narrative, the danger to the narrative, the danger to the country, it means that he's in big danger. That's why we have all the contenders and all other new alternatives are appearing.
Yeah, Michel, it seems like the West is looking for a new surrogate because, Time magazine, The Economist, you can't get any more mainstream than that. And words like delusional is coming up. And it essentially paints a picture of that Zelensky's fighting a two-front war against Russia and his own generals. Go ahead, Michel.
Yeah, well, I believe that, I've read Seymour Hersh's paper.
Oh, okay. I want to get to that. Well, go ahead. I was going to mention it. Go ahead. Jump right in and talk about it. Go ahead.
Well, I read Seymour Hersh's paper in which he says that there are negotiations taking place between Valery Gerasimov and Valery Zaluzhny in Ukraine. concerning a peace deal that might be arranged between those two. I'm convinced that there are such negotiations because at this point, I think that the Americans are desperate in finding a solution, a way out of this conflict. But exactly for that reason, I'm not convinced that the Americans are out of the picture. They are involved, I believe. The best scenario for the Americans would have been to continue the war beyond the presidential elections, with the hope that maybe the Ukrainians would be winning. But now that we know that they are losing, it's going just to be terrible for Biden's re-election. So there must be a plan B. And I believe that that plan B is forcing negotiation for a peace deal right now. And the position of the Americans will be, well, there was an aggression, an unprovoked aggression. We helped Ukraine, and now they have decided all by themselves to reach a peace deal with the Russians, and we respect that. That would be the plan B that hopefully, in the mind of Biden, will help him win the election.
Yeah, well, it's dreadful to think what is in the mind of Joe Biden, but that's a topic for another program. Dimitri, since, Michelle already brought up the Seymour Hersh piece, which I wanted to delve into, but we're already into it. So it's an interesting piece. I don't buy it. I think it's more of a trial balloon than anything else to see what the reactions would be, because the Russian military it's not a free agent, okay? And I'm not really sure what that has to say about the Ukrainian military, though I would like to point out that Zaluzhny is very much respected in Russia. That adds to this trial balloon kind of a narrative here. But, the whole point is that Kiev is running out of options here. I don't think the Americans will really abandon Ukraine. I just think they'll just keep it on life support before the election. Dimitri.
Well, they certainly don't want to see a full-scale collapse, because that would be a narrative that would be beyond the control of even the Biden administration and the corporate media in the United States. That would, I think, reveal to the entire world that this project was ill-conceived from the outset, and that there's no way to deny that this has resulted in a strategic defeat for NATO and for the Biden administration. So yes, I do agree that they're likely to keep it on life support, but the last several months have seen not necessarily the lowest levels of support coming from the United States, but certainly relative to levels of support during this so-called offensive, very, very low. There's a statement coming out of the White House warning, I believe it's coming from the Congressional Budget Office, that they're almost out of money. 97% of the funds have been spent. The new Speaker of the House, who apparently has a history of voting against aid for Ukraine or increased amounts of aid for Ukraine, doesn't seem to be in any hurry to come up with more funds for this proxy war. So the situation is looking rather grim. I think that the most fateful sign for Zelensky himself is that there's literally a beauty pageant going on for the successor to Zelensky at the moment. You have Alexei Arestovich coming out, becoming increasingly assertive in his criticisms of the way Zelensky has handled it. Valery Klitschko, the mayor of Kiev, just gave an interview in which he effectively sided with Zaluzhny. Zaluzhny is now openly stating that this war effort, which is a stalemate, which is, I think, fair to say, a euphemism. In fact, the Ukrainian military is on the verge of collapse, as far as many of us can tell. So it seems to me that Zelensky is besieged on all sides, and that the greater threat to his survival at this moment is not Russia, but his internal enemies.
Yeah, well, Vladimir, it's very interesting I think the last time we spoke, which was a while ago, that we mentioned that eventually there'll be the blame game. Who's to blame, okay? Was it, the Ukrainians not following advice from NATO, NATO supporting the wrong person? I mean, this essentially tells us that we're in the end game. The end game can last a while, but we are there. Vladimir.
That's absolutely true, and that's why your image of a trial balloon is a very correct one. Everybody now is thinking and looking for exit strategy. Everybody wants to cover their backside. We have United States with the elections, and obviously Democrats are in a pickle. They cannot throw good money after bad money, knowing that Republicans will capitalize on that. They cannot stop just supporting it without anything happening. So they are probably thinking of some kind of alternative. And since Zelensky is connected with "we're going to win, we're succeeding," some alternative should be found for him. I think Zaluzhny is a possible alternative because besides the United States and NATO pressure, what leaders in Kyiv have a pressure from their nationalist, violent thugs. Right. Primarily centered around Western Ukraine, right. And they, even in numbers, they are not that big in terms of their violence and assertion they can do. And so I think people like Arestovich, they might appeal to intellectuals in Kyiv, but these guys, are tough. So the only person who somehow can convince them that we can make deal with Russia is some tough general. So in that sense, I believe that Zaluzhny might be
Vladimir, so Nixon goes to China type thing? Is that what you're saying?
Yes.
Okay. Well, let's go back to Michelle in Montreal. It's very interesting because it gets if you have a change of president in Ukraine, then you can rationalize it. He was the wrong guy. He was good at war, but not ending it. He couldn't win it, and that kind of shifts the narrative to the advantage of the West. Well, we did all we could. Michelle.
Yeah. Well, perhaps I'm too fast in my conclusion, but it seems to me that the problem with the American administration is that is revealed by the implication of U.S. support for Israel at this time. They have an incoherent approach, and I think that the biggest mistake made by the Americans was to interpret Russian restraint as a weakness. Before 2014, Russia simply repeated its opposition to NATO expansion. After 2014, they were favorable to the Minsk Accords. Before the war in December 2021, they wanted to negotiate on the basis of a treaty concerning European security. Immediately after the beginning of these special military operations in April 2022, they were just about to arrive to a peace deal with Ukraine. At each moment in time in the escalation of the conflict, things were interpreted by the West as a weakness on the part of Russia. And that was their biggest mistake. And I think these kind of things will be revealed in the next few months.
I have to jump in here. We're going to have to go to a hard break, gentlemen. And after that hard break, we'll continue our discussion on Ukraine. Stay with RT.
In the 1870s, the colonial expansion of the British Empire in the Nile Valley increased. The British decided to get complete control over Sudan. However, the deeply religious people of that country did not want to obey foreign laws. The unceremonious intervention of British officials led to people's discontent. Its spokesman was the theologian Muhammad Ahmad, who proclaimed himself the Mahdi, the Messiah. He began to gather an army against the invaders. By 1884, most of the Sudanese cities were in the hands of the Mahdists. Great Britain decided to intervene directly, but the troops of Ahmad gave the invaders a drubbing. In 1885, the rebels took the capital, Khartoum. The defeat of Britain was total. Only by the very end of the 19th century, after the death of Ahmad, the British were able to regain their control of Sudan. Unable to defeat the living Mahdi, the British took revenge on the dead one. His remains were drawn out of the mausoleum and thrown away into the Nile. Ahmad's head was brought to England as a trophy. However, the victory of the Mahdist revolt became the first successful action of the peoples of Africa against the colonial oppression, and remained a dark stain on the reputation of the British Empire.
Welcome back to Crosstalk, where all things are considered. I'm Peter LaBelle. To remind you, we're discussing Ukraine. Okay, let's go to Dimitri in Montreal. At the very end of our discussion before we went to the break, Michelle was talking about misconstruing so-called Russian weakness. I think it's a fascinating point, and I think it really hits the mark, because there's been fundamentally a misunderstanding of Russia all through this, okay, every step of the way. Old stereotypes, what would they reveal their self-delusions about Russia? But all of this discussion of going back to the Hirsch issue is that Russia will accept this for this, and they're always drawing the board and assuming what Russia wants and what it'll accept. And again, they're making that fundamental mistake. Russia will decide what it wants when it wants, and it has nothing to do with the conversations going on in The Economist or Time magazine. Dimitri.
Yeah, one thing I want to say about the Seymour Hersh article, by the way, I completely agree that there was a complete misinterpretation of Russia. There has been. This is a profound problem within the foreign policy elite of the United States and the West generally, is that they just don't understand the non-Western world. They barely understand their own world, let alone the non-Western world. This problem extends throughout the West in the foreign policy elite. It extends to not only Russia, it extends to China, other parts of the non-Western world. And we've seen this in dramatic fashion now, but they also have overestimated the capacity of the West, both the economic capacity of the West to impose its will upon countries like Russia, which has a much larger economy than we're told. On a purchasing power parity basis, for example, it now has an economy larger than the size of Germany's. On a nominal GDP basis, which is basically a meaningless manipulated figure, it has a much smaller economy. And this type of misconception of the economic strength of the United States is very emblematic of the foreign policy ignorance in the West. But I want to say one thing about the Seymour Hersh piece, which I found rather fascinating. The suggestion that the Russian government would accept NATO membership for what remains of Ukraine on condition that the West not that NATO not station forces or offensive military weapons on Ukrainian territory. Initially, I thought that this was preposterous because it's now been admitted by the West, and it was clear from the outset to those of us who have any objectivity that NATO was a core issue for the Russian government.
Right.
But it occurred to me that this is actually more plausible than might seem on its face, because I think the Russian government may understand that the United States would have no interest whatsoever in NATO membership for Ukraine if it was deprived of the ability to place its forces and its offensive military weapons on Russian soil. That was the whole point of NATO membership for Ukraine. It was never about protecting Ukraine with an Article 5 guarantee under the NATO treaty. If they can't put their forces there and threaten Russia and contain Russia, then why would the United States want to take on the burden of potentially having to come to Ukraine's defense in the event of a flare-up in military hostilities between Russia and Ukraine? The whole point was to threaten Russia. So I think that this actually, if it's true that this is on the table, NATO membership without the ability to put NATO forces on Ukrainian soil, I think it may be a clever play by the Russian government, because I don't think the Biden administration would accept that at the end of the day, and you'd end up with it's not a NATO at all.
Yeah, but Vladimir, any part of Ukraine in NATO, assuming that Hersh's reporting is correct, well, it would come under Article 5. And what would stop a local elite in Ukraine from starting a conflict with Russia, which would pull in the rest of NATO. I don't understand that. That's a tripwire that Russia would never accept, and NATO foolishly should not accept, because when everything is said and done, the Russians and the Ukrainians are not going to sit down and shake hands, maybe for generations. Vladimir.
Well, it has to be seen. Definitely has to be calculated and to be seen. But what emerges from all our discussions, including what Dmitry and Michelle said, is that very serious